high yield systems, starting with CVS, embryo. So heart morphogenesis, first functional organ in vertebrate embryos. Four spontaneous beats spontaneously by week 4 of development, right? So you can remember week 4 by thinking about the cavities in the uh, heart. So there's like two ventricles, two atria, so that's four cavities. uh, Cardiac looping, primary heart tube loops to establish left-right polarity, begins in week 4 of development. Okay. uh, Defect in left-right dynein, involved in left-right asymmetry, right? So that's when you have dextrocardia. That's when you have the heart on the other side, or the epic. You can feel the epic beat on the right side on the fifth intercostal space instead of the left. It as seen in Cardiovascular syndrome. That's the one where you differentiate between this and cystic fibrosis. Septation of the chambers. Okay, so uh, right, so four chambers, not cavities, but four chambers. So week 4, it starts beating. Atria. Septum primum grows towards endocardial cushion, narrowing ostium primum. So this is septum primum right here, and this is your endocardial cushion. So first thing that happens that it goes to this goes towards that, and wait, yeah. So septum primum, and this is called the ostium primum between the two. This will change as it goes, as it develops, right? So this is called different names. But for now, it's ostium primum, and septum primum goes towards endocardial cushion. That's it. Second, ostium secundum forms in the septum primum due to cell death. Ostium primum regresses. Okay, so after there's a development here, let's make that green. Right, so after this thing goes and grows over here like that, get a little thicker, too thick. Okay. So after that grows, what happens? Some parts of the septum primum, uh, apoptosis happens, so it cell death happens, and when cell death happens, the gaps now are called ostium secundum. Okay. Okay. So now you have ostium secundum. So ostium secundum forms in septum primum due to cell death. Ostium primum regresses. Then 3. Septum secundum develops on the right side of the septum primum. Okay, so again, septum secundum develops on the right side of the septum primum as ostium secundum maintains right to left shunt. Okay, so again, right to left shunt means this one is going to push over here, right? Because you have to remember it's still a fetus, right? So they don't have all the cardiac muscles built, so majority of the blood coming in. Okay. So majority of the blood coming in are from the superior vena cava and the inferior vena cava. So the force of that is going to build up the right to left shunt for now, okay? Until the baby is born, and then the left ventricular, there's less resistance in the lungs, and there's left ventricular mass, like the muscles that will work as well. So that will change the polarity of the shunt. But for now, it's going to be right to left shunt. So this is important. And fetus, there's right to left shunt because of the blood coming in from the thing, and there's too much resistance in the lungs, so it can't go through the pulmonary artery, so it goes through the ostium secundum. Okay, so as ostium secundum maintains right to left shunt, then what happens is septum primum. So now we have this septum secundum forming, and we have ostium, right? So what we're gonna have now is, let's do this blue. So this is gonna grow towards the cushion as well, and this is gonna come up here as well, right? And we already have ostium secundum. So septum secundum develops on the right side. This is the right side of septum primum. That's the septum primum. As ostium secundum maintains the right to left shunt. So as this is developing, right, there's still some gap here, so the blood's still going to flow through here to here. Okay. So over here now, we have septum secundum expands and covers most of the ostium secundum, right? So this was ostium secundum, so it's going to come in and block that up to there. The residual foramen is the foramen ovale. So it covers it, but it's not attached to this yet, the septum primum, right? Then you have the remaining portion of the septum primum forms the one-way valve of the foramen ovale. So now you have this septum. Okay. So this thing now is a valve, right? So this thing is a valve. So when this thing is coming in, this is going to open up and let it flow through and then come back, flow through, come back, flow through, come back. Okay. Why is that there a pulse? It's not that it's a pulse more so. It's just that the mother's pulse is pushing the blood through, so that pulse is going to transfer. That's why, it goes like that. It's very minute, so okay. So septum secundum expands and covers most of the ostium secundum. Then the residual foramen is the foramen ovale. Remaining portion of the septum primum form the one-way valve for foramen ovale. That just means that it can go from here to here, but that's it. It can't come from here to here, because when it does that, it's going to push septum primum against septum secundum and closing the valve, so it can't do that. So it's a one-well valve. Septum primum closes against septum secundum, sealing the foramen ovale soon after birth because of increased left atrial pressure and decreased right atrial pressure. So why is there decreased right atrial pressure? It's because the lungs have opened up now. So right atrium can go into right ventricle, and then right ventricle can enter the pulmonary arteries. Okay. That's why there's a decrease of this. And now there's before there was like zero pressure in left atrium, but now there is some pressure coming in from the lungs as well, because now it's pushing the blood into it, right? Although the pressure is not going to be too much, because remember, they're not like big vessels, it's just small. So it's going to be like 5 mmHg of pressure kind of thing. Okay, compared to aorta is 190. Okay, septum secundum and septum primum fuse during infancy, early childhood. Okay, so in the early childhood, you still have this valve functioning. Not functioning, but it's still open, right? It's not fused to septum primum. So they're saying that it fuses during infancy or early childhood. So this happens after birth. Okay, so forming the atrial septum. If for some reason there is a cyanosis of some kind, we try to keep this open, or we try to keep the PDA open, or one or the other, to maintain the circulation. The common patho, I guess. So yeah, so now we have degenerating septum primum. This one we don't need that, and this and this make the valve, and then after they get fused, it's closed. Then no blood goes by. Okay, so patent foramen ovale, that's caused by the failure of septum primum and septum secundum to fuse after birth. Okay. So most are left untreated, can lead to paradoxal emboli, venous thromboemboli entering the systemic arterial circulation through right to left shunt, as can occur in atrial septal defect. Right, so what does that mean? Say there's a question about a person who was on a road trip, or he's been traveling to tropical islands because he's not a doctor, so or a student, so he can travel and enjoy his life. So he takes the plane, right? So what's the number one thing that can happen for step one if you're on a plane? It's DVT, right? So deep venous thrombosis. Then that gets detached and becomes an emboli, and then it goes through the system, right? So normally the emboli uh, goes through the system from the right atrium to right ventricle to pulmonary artery and gets stuck there, and that's why you have respiratory distress and respiratory embolism. But sometimes what happens is it doesn't just end up in the uh, it doesn't end up in the lung. Instead, it ends up in the brain. So how does that happen? Because it's hard to get through the lungs, right? Because it has a lot of narrow arteries, so it's impossible to get through that. It's kind of acts like a sort of a filter, right? So what happens is it goes through this. So sometimes when um, they're they're sitting down and then they get up, so there's a reduction in venous return, so that can make the shunt go from left to right to right to left, right? Or any activities that does a temporary reversal of the shunt. So then this thing, if it's not fused, the embolism or embolus will come in and then flow through here, right? So it comes from superior vena cava. Sorry. Okay. So it can come from superior vena cava or the inferior vena cava, right in here, and then the embolus can just stay here somewhere and just keep flowing over here, or it can go through, right? But there could be chances that while this is here, you do something or some kind of activity that makes this go from a left to right shunt. So left to right is just going from this to this, or left ventricle throwing the blood into the aorta. Instead of that, it's going from the right atrium to left atrium, right? So it flows through that to there. Then this goes after everything's normalized again. Then this goes from left atrium to left ventricle, and then through the aorta, and from aorta to the coronary to cerebral, right? And then you have a embolus in the brain causing stroke and ischemia, right? So that's how that happens. So that's what this means, that it can lead to paradoxical embolus, emboli, venous thromboemboli entering the systemic arterial circulation. So now, since it came from SVC or IVC, that those are veins, right? Not arteries. So that's why it can enter from venous blood into the oxygenated or arterial blood, right? Which is going to be in the left atrium. So it can lead to paradoxical emboli, which is venous thromboemboli entering the systemic arterial circulation through right to left shunt, as can occur in atrial septal defect. Okay, so remember, so atrial septal defect happens because there's a failure of fusion between septum primum, the green one, and septum secundum, the blue one. Okay. Heart morphogenesis continued. Okay, so now we're doing ventricles. So how does the ventricle develop? So where we ended up was this septum right here has been made, and this is the endocardial cushion. Okay, so now we have the. Okay, so let's read. One. Muscular interventricular septum forms. So now this is the muscular interventricular septum. Right there. Oops. Right there. Right, it's between the two ventricles, right there and there. Then we have aorticopulmonary septum rotates and fuses with muscular ventricular septum to form membranous interventricular septum, closing the interventricular foramen. So we have the interventricular foramen right there. Okay, so what happens is the aortical septum rotates, right? So this is the aorticopulmonary septum, And then what this is gonna go, actually it's gonna go the other way. So this is attached to this, and imagine there's a wall right there, right? So a wall that's attached to this is now being twisted, right? And it's on the back there, so you can't see this side on over here. But then you have this side and twisting it. So now this side is behind here, and this is a new side here, right? So that's how it's twisting. If you can make that understanding. So just imagine you have like a, I don't know, let's say a piece of clothing that's crumbled up. So you rolled up the piece of clothing, right? So when you're rolling it, that's twisting it, right? So that's how it twists over here, right? So imagine your hand is here and your hand is here, and this hand is rolling forward and this hand is rolling backwards. So that's the kind of twist that's happening here. Okay, so aortical pulmonary septum rotates and fuses with the muscular ventricular septum. So these are the muscular ventricular septum, right? This is the interventricular and this is the muscular ventricular septum. So this one attaches to this side and this end attaches to this side. So with muscular ventricular septum to form membranous interventricular septum. Okay, so it does that and then it makes this as well. So this is going to attach to this, right? So that's how it's going to be attached to muscular and interventricular septum. Okay, closing the interventricular foramen. Since this is the foramen, so if you can imagine if this is attached to this from here to here, all of this going to be covered up with, you know, the septum. So there's no foramen now. That is ugly. Okay. So now we have growth of endocardial cushions separates atria from ventricles and contributes to both atrial septation and membranous portion of the interventricular septum. Again, growth of so that's the endocardial cushion. Separates atria and ventricle. Okay, so it separates the atria and the ventricle and contributes to both the atrial septation and membranous portion of the interventricular septum. So this, you can imagine, is the important structure, right? Because this is the structure that divides the atrias and the ventricles. That's all it's saying. So it separates atria from the ventricles and contributes to the atrial septation. So it also divides the two atrias, and because that's right atrium, that's left atrium, so it's going to divide those two. And now that it's over here, it's going to divide the two ventricles as well, and ventricle and atria and ventricle as well. Right? So what happens when this doesn't fuse to this, right? So you get a ventricular septal defect. Most common congenital cardiac anomaly usually occurs in membranous septum. So when this fusion doesn't happen, this is the interventricular foramen stays open, right, on this side. This is fused, so you won't have RA and RA and RV or LA and LV, but you will have LV and RV communication, right? So again, ventricular septal defect, most common congenital cardiac anomaly, usually occurs in membranous septum. So that's your membranous septum. Okay, and that's the end of the hard part. Outflow tract formation, neural crest cell migrations, which leads to truncal and bulbar ridges. So since we need to know what those are, let's just bring this over there. Okay, so when it's made, this is what the thing's going to look like, right? So okay, so you have neural crest cells, cell migration. Remember, there's epiblast, hypoblast, and then and it turns into like bilaminar disc turns into the three layers, endoderm, mesoderm, and epiderm, or whatever, ectoderm. Sorry, right? So the bilayer disc. This is where it comes from, neurocrest cell migrations, right? So then you have truncal and bulbar ridges that spiral and fuse to form aortico pulmonary septum. Okay, so that's this part right here. And then you have ascending aorta and pulmonary trunk. So after this thing twists around like that, these arrows are showing you the twisting of it. So this doesn't move. It's this part that moves. So that's the way. That's why it causes a, you know. Again, imagine you're holding on to this end, right? You're holding on to this end, and then you're holding on to this end, and this is not moving, but you keep twisting it this backwards, right? Or the way the air is going. So what's gonna happen? You're gonna have a roll of clothing that's gonna end up like knots with like a little rolled knots, right? Like that. So that's how the heart is formed. Ascending aorta and pulmonary trunk. So you have, this is the truncus arteriosus. So that's the truncal, and this part is called the bulbar part. Okay, or and then the ridges would be the bulbar ridges. So that spiral and fuse to form aorticopulmonary septum. It leads to ascending aorta and pulmonary trunk. Just to be thorough, this is what I mean. So roll clothing. Hopefully nothing bad comes up. So yeah, some kind of like that, right? So not this, uh, organized, but like just a random, say, a towel, right? So when you roll it and then you hold one end, the other end, and then you keep rolling this end, but not move this, you're gonna get a little knot that looks like the heart, like that, right? Okay. Conotruncal abnormalities associated with failure of neural crest cells to migrate. So you're gonna have transposition of great vessels. Okay, that means rather than having, let me just go with that part. Where'd it go? It's still in physio. Okay, so transposition of great vessels. Rather than having the pulmonary arteries in the right ventricle, you have the aorta in the right ventricle. And rather than having the aorta in the right ventricle, you have pulmonary arteries in the left ventricle, sorry. Rather than having it in the left ventricle, you have pulmonary arteries in the left ventricle. So you can imagine that this is a closed system, right? Because the blood comes from the lungs, enters the left atrium, goes to the left ventricle, then this pumps it out into the pulmonary artery instead of the aorta, right? Then it goes back to the lungs, comes in and that. So you're going to have cyanosis, right? Cyanosis is basically no oxygen. Okay. Tetralogy of Fallot is a triad of 4 things. We'll do that as well. Persistent truncus arteriosus, we'll do that as well. Okay. Valve development, aortic. So these are just the outflow formation abnormalities. Okay, these 3 at least. Then you have valve development, aortic pulmonary, derived from endocardial cushions of outflow tract. Mitral and tricuspid, derived from fused endocardial cushions of the AV canal. That's atrioventricular canal. That would be your mitral and tricuspid, right? And these are your aortic and pulmonary valves. Valvular anomalies may be stenotic, regurgitant, atriotic, for example, tricuspid atrasia, or displaced, for example, Epstein anomaly. So stenotic is it's stenos, so there's no flow, or it increases pressure, and that's when it opens up. And then you have regurgitant backflow of the blood, or atriotic, like tricuspid atrasia, so you don't have a valve there. Or displaced, like Epstein anomaly. So it's the tricuspid gets there's atrialization of the ventricles, right? So what that means is normally you say this is your uh, right ventricle and this is your uh, right atrium, right? And then you have a valve there. But now what's happening is your atrium in Epstein anomaly, it extends into the right ventricle, and now your ventricle that used to be like that, now is like this. Okay, so it has atrial part is in the ventricle, so it's called atrialization of the ventricles. Okay. Hold on, let me check. Atrialization of the ventricle, it means, right? Okay. Now we're doing aortic arch derivatives, and they develop into the atrial system, right? So first is max. That's the maximum number you can have in a classroom, I guess. So part of maxillary artery, branch of external carotid. First arch is maximal, right? So maxillary artery is a branch of external carotid artery. Side note, you guys should know the branches of external carotid artery. They're like 8, right? So you have, starting from the top, you have facial artery, then the tongue lingual artery, then the thyroid, so superior thyroid, and behind it you have ascending pharyngeal artery, and then you have the ears, so posterior auricular artery, and behind it you have occipital artery, superficial temporal artery. So part of this would be the maxillary artery, I guess. Right. So maxillary artery, external carotid artery. First arch is maximal. Then you have second stapedial, S for S, so stapedial artery and hyoid artery. Second stapedial artery. Okay. Okay. So where is that? So we have external carotid, and you have internal carotid here. You have common carotid coming in and making this. We don't have first here. We don't have second here either. Okay. So the third is common carotid artery and proximal part of the internal carotid artery, right? So this would be the proximal. Anything above would be distal. So when you're doing proximal and distal, you're always thinking in terms of where the core is in your body, right? So anything near the core would be proximal. Anything away from the core would be distal. So that's what it means. Common carotid artery and proximal part of the internal carotid artery. So that would be this part. C is the third letter of the alphabet, so you can remember it like that. So the third arch is derived from C for common carotid artery. Okay, and then you have the fourth aortic arch, right? This part on the left aortic arch. On right, it makes the proximal part of the right subclavian artery, right? That thing right there. So fourth arch, four limbs, systemic. This is the important one, the fourth, because it's not the same on both sides, and the sixth as well. So this is the proximal part of the pulmonary arteries, and on left only. Okay, so this is the left side, so it's only on the left, and this is the one that makes the ductus arteriosus. That's why it's the important arch. So sixth arch equals pulmonary, and the pulmonary to systemic shunt. That's the ductus arteriosus. Okay. So why does this exist? Right? Maybe they tell us here. But yeah, they'll tell us over here, so we'll do it there. Okay, so again, revision. First is the maxillary artery. Second is the stapedial artery. Third is the common carotid artery. Fourth, on the left, it makes the aortic arch, and on the right, it makes the right subclavian artery. And on the sixth is it makes the ductus arteriosus. Only on the left. Okay. Nothing on the right. So here you have right recurrent laryngeal nerve loops around product of fourth arch. Okay, so the fourth arch is right subclavian artery. So right recurrent laryngeal nerve goes around it or loops around it. Remember that. It's part of an anatomy question. And then you have left recurrent laryngeal nerve. Okay, so this was right recurrent laryngeal nerve, and this is the left recurrent laryngeal nerve. That's easy to remember because it's right and left. And it's laryngeal loops around the product of sixth. That's the important one. Okay, ductus arteriosus. Okay, and this would be the arch by the fourth. Right on the left, it makes the aortic arch. Cool. With that, heart embryo. So embryonic structures, and it gives what it gives rise to. Okay, so truncus arteriosus, ascending aorta and pulmonary trunk. Okay, that's the initial part of the thing that goes like, you know. So see, this is the heart, this is the aorta, right? So it's this part. This is called the ascending, and this is like the whole aorta, right? So this is descending. This is the aortic arch, and the thing that attaches this to the heart. Between the arch and the heart, it's the ascending aorta. Okay. So the truncus arteriosus, it's in the name, right? It makes the two trunks, the trunks for the aorta and the pulmonary trunk. Then bulbus cordis. This is the smooth part, outflow tract of left and right ventricles. Okay. These are the ventricles, and left and right smooth parts are made by bulbus cordis. Primitive ventricle, that's trabeculated part of the left and right ventricles. Okay. You have primitive atrium, trabeculated part of the left and right atria. Then you have left horn of sinus venosus, coronary sinus. Okay. Then you have right horn of sinus venosus. Okay. Smooth part of right atrium. I'm going through this because they don't really test you on these. So endocardial cushion, atrial septum, membranous part, or the interventricular part. We already did that one. Endocardial cushion, so it makes the septums. And the AV and semilunar valves, right? So atrioventricular and the semilunar valves. Then you have right common cardinal vein and right anterior cardinal vein. This makes the superior vena cava. Posterior cardinal, subcardinal, and supracardinal veins. That's inferior vena cava. Okay, and then you have primitive pulmonary vein, which makes the smooth part of the left atrium. There's no point of spending time on this because we probably forget it as soon as we're like on the third page, right? But the ones you should remember, I'll just go over that one. If they ask you, they'll ask you about the truncus arteriosus because that's an easy one. They might ask you about what makes the superior vena cava and the inferior vena cava. I don't, and maybe this too. Left, no, they don't ask this. So, yeah. do these on your own time because I'm not going to bother with them. Okay. Fetal circulation. So this is an important topic. Um, the questions can come like, okay, so how uh, which vessel takes out the deoxygenated blood from the fetus, or which one brings in the oxygenated blood from the mother, uh, or which artery travels through the fetus that carries the oxygenated blood, or vice versa. So these are the type of questions they'll ask, and they might even ask what is the first. No, wait. What did they ask? Which? Okay, a blood that comes through the umbilical vein. Uh, it'll come to me as we go along. So let's read this. Blood in the umbilical vein has a PO2 of approximately 30 mmHg of pressure and is 80% approximately saturated with O2. Umbilical arteries have low O2 saturation. To get this is why mothers during pregnancy have increased uh, blood volume, have hypertension, increased GFR, and all that stuff. Is to reach this. So they increase blood mass, blood volume, everything to have this happen. And they also hyperventilate during pregnancy, right? Normally it's around maximum is around 20 breaths per minute, but for pregnant ladies it goes higher up. Their heart changes as well; it remodels a little, all that stuff, and so that the fetus can have 80% saturated oxygen. If I said baby, I'm sorry. I know that's a controversial topic. Okay, three important shunts. First is ductus venosus. Okay, so what's the importance about this? Its blood entering fetus through the umbilical vein is conducted via the ductus venosus into the IVC, right, bypassing the hepatic circulation. Okay. So it's again, you don't need this kind of circulation because you don't have anything in your abdomen, right? So you don't need the port of circulation yet. The splenic systemic circulation, right? You don't need that. So initially what it's going to do is just going to bypass it because you get your nutrients and stuff in the fetus from the mother anyways, so you don't need it from here, so there's no blood there either, and obviously the fetus is not having chips or pizzas or anything, so there's no point of that either. So it bypasses the whole hepatic circulation, so it goes from here, so it starts from here again, the placenta comes in the umbilical vein, 80% saturated oxygen. Remember, it's flipped around. It's vein, but it's still oxygenated blood. So it bypasses this. And how does it do it? It does it through ductus venosus. After it bypasses it, what happens? It goes into the IVC. Okay, and this is, I think, the one that they ask. The umbilical vein, which one after the first duct it passes, or after it travels through the duct, which vein does it go into? So it's the IVC, not the superior vena cava, the inferior one. Okay. Most of the highly oxygenated blood. Oh yeah, they also ask which chamber will have the highest oxygenated blood. So that's the question I was looking for. Okay, so they ask in a fetus which chamber will have the highest oxygenated blood. So that would be your right atrium. Okay, normally in a normal person it's the left atrium, right? Because it comes from the lungs after getting oxygenated. So right atrium first, and then it goes to the left atrium second, and then the left ventricle, and then through and through. Why? Because there's no point of going into right ventricle. Even if it does, it's going to be backed up by the resistance of the lungs, so it's going to be backflow of, or like, stagnant blood kind of thing. Not stagnant, but it's very less amount of blood that goes into the lungs. So most of the highly oxygenated blood reaching the heart via the IVC is directed through the foramen ovale into the right atrium, right? So it goes through that. Then we have, so that's another thing that happens in a baby that doesn't in a normal person because it's fused. Which ones? The septum primum with septum primum with the septum secundum, and this is a one-way valve, right? And with the right to left shunt. We have deoxygenated blood from the superior vena cava, passes through the right atrium, goes to the right ventricle, and goes to the main pulmonary artery, right? And so why is this not stagnant, right? I said that there's resistance in the lungs and everywhere. So what happens to the blood that goes through this? If the blood doesn't keep moving, it's gonna clot, right? So what happens is there is a bypass over here going from the pulmonary artery straight into the aorta, right? So that bypass is called this ductus arteriosus. So SVC passes through the right atrium, so it comes from up here, so it has a momentum going downwards, right? So it goes down through and through, whereas IVC has a momentum going this way. So this momentum is going to take it to the right ventricle into the pulmonary artery, and from the pulmonary artery, it's going to go through the ductus arteriosus, right? So main pulmonary artery to ductus arteriosus to the descending aorta, okay? And the shunt is due to high fetal pulmonary artery resistance, okay? So the lungs are creating the resistance. And then after it reaches that, it just goes through and through, downwards. Cool. At birth, infant takes a breath. So when that happens, the lungs inflate, and then the resistance against the... Because how does the resistance happen, in case you can't make that out? So this is the vessel, and the lung is... So imagine all the vessels are like this, right? And it's in the lungs, right? And lungs are deflated, right? So it's pushing downwards onto the vessels. So when it's inflated, what happens is now it's inflated, and now the vessels are not getting pushed external force, right? By external force. So now the resistance is decreased because of that. So decrease in resistance in pulmonary vasculature leads to increase in left atrial pressure, right? Okay, so let's get rid of these. Okay, so at birth, a decrease in resistance, increase in pulmonary vasculature, so increase in left atrial pressure. So normally, since there was nothing coming from the lungs into the left atrium, it was just the amount that was coming through here, right? Which wasn't much. So now there's increase in pressure because now it's getting it from the lungs itself, right? So that's why there's increase in left atrial pressure versus the right atrial pressure. So now the shunt is gonna reverse. Okay, so left atrial pressure is increased versus the right atrial pressure. So then the foramen ovale closes, now called fossa ovalis. Okay, so increase in O2 from respiration and decrease in prostaglandins from placental separation will lead to closure of ductus arteriosus. This is an important line. Okay, so you need a decrease in prostaglandins for that, and you need closure. You need increase in oxygen. and decrease in prostaglandins to close the fossa ovalis. Okay, that's why if for some reason there is a patency, we give NSAIDs, for example, indomethacin, ibuprofen, or acetaminophen helps close the pain ductus arteriosus. Okay, they didn't talk about ovalis. So, in case there is, for some reason, cyanosis because of some abnormality, we would try to keep this open by giving them prostaglandins. Okay, so as long as you keep giving the prostaglandins, these two won't fuse, and that is one of the methods we keep the circulation saturated. Okay, okay. So say this thing, prostaglandin. Sorry, the ductus arteriosus stays patent. That's called patent ductus arteriosus, so PDA. We can help it to, you know, regress or close by giving indomethacin or ibuprofen or acetaminophen, which help close the patent ductus arteriosus. How? It decreases prostaglandin. So ligamentum arteriosum, remnant of ductus arteriosus. So after it's closed in adults, it's known as ligamentum arteriosum. So the fate of PDA or ductus arteriosus, just ductus arteriosus, is called ligamentum arteriosum. Okay. Endomethacin ends the PDA. So prostaglandin E1 and E2 keep PDA open. So we also try to keep this open as well in case of cyanosis. So whichever one or the other. I guess it's usually this one, not the ovalis, fossa ovalis, but it's going to be this one that you try to keep open. They won't test you on the ovalis one, I guess. So we give prostaglandins to do that. Okay, fetal postnatal derivatives. Fetal structure. How much time do we have? Okay. Fetal postal derivatives. Fetal structure, postnatal derivative, and nouns. Ductus arteriosus, ligamentum arteriosum, near the left recurrent laryngeal nerve. Ductus venosus. So that will turn into ligamentum venosum. Oh yeah, remember, on this side it's this, and on the subclavian side it's going to be right recurrent laryngeal nerve, right? That was over here, this part, that told us about that. And this was a derivative of fourth arch, whereas on the ligamentum arteriosum is product of sixth arch, or PDA was product of sixth arch. Right? Okay, foramen ovale is called fossa ovalis. Then you have allantoin. This is an important one. It's called the median umbilical ligament. We'll come across this in GIT as well. Urchus is a part of allantois between bladder and umbilicus. This is important because if there's some bits that didn't fuse and others did, then that'll create a cyst with urine inside. So that's what's important about that. Allantois turns into urchus. Okay, so patent allantoin or patent urchus, I guess. One or the other. Umbilical arteries, medial umbilical ligaments. So that's what that turns into. And then you have umbilical vein, turning into ligamentum teres hepatis, round ligament. This is an important structure as well. It's contained in the falciform ligament. So we'll do at least like 3 of these in GIT or repro. I forget now. Probably GIT because that one is on like the liver, in front of the liver. Okay, we have anatomy. Oh yeah. So before we go on, LA mass, myxoma, amorphous extracellular matrix, mobile mass, and then you have thrombus, which creates the atrial fibrillation or flutter. Uh, the difference between two is that this one is adherent to the cardiac endothelium. Remember this? Just recently on the group, someone put up a picture from Twitter. Not a picture, but a video. So I think I have that open here. So this is a myxoma, the one that looks like Casper the Friendly Ghost. Right. So that's hypnotizing. But so that thing right there, the vegetation or like whatever, the growth here is called the myxoma, right? So the definition of it is that it's amorphous extracellular matrix, okay? And it's a mobile mass, it moves. Whereas the adherent one would be, say, this is a valve, and then this is a mitral valve with the atrium like that, right? So myxoma would be attached to one of the valves over here, right? The one that moves. But the thrombus would be like somewhere here, inside this layer over here, attached to that, or but it's not gonna move with this. But what's it gonna do? So say when this opens up, the blood goes here, right? Normally, if this wasn't here, but now that this is here, when this opens up, this is gonna create a different type of suction. So now there's a turbulent flow, right? Now that it's gonna go like this, and then this, and then it's gonna go through because of this. So that's what it creates, which is not good, because that will lower your diastolic as well and mess up your whole rhythm, to the point where it creates arterial fibrillation or flutter. Okay. Also, you have pulmonary veins coming in here, and near that, you have the AV valve or so. No, not AV valve. Sorry. You have something there. We'll do that then. Okay, so anatomy. Heart anatomy. You have left atrium is the most superior part of the heart. So that's left atrium. Uh, Normally, this is how you're going to see it. Okay, and this is how you're going to see a photo on a chest scan. So left atrium will be the one closest to the aorta. Okay, it goes pulmonary vein, then this thing, and then aorta, and on the middle you have left atrium. Left atrium, again, just imagine yourself, the one outside touching the outside wall is the right ventricle, and the side wall is going to be the left ventricle, and the one like right behind your throat is going to be the left atrium, and the one on your back is going to be the right atrium, right? So left atrium is the most posterior part of the heart. Enlargement of the LA or left atrium, for example, in mitral stenosis, can lead to compression of the esophagus or dysphagia, and or the left recurrent laryngeal nerve, a branch of the vagus nerve causing hoarseness, uh, Ortner syndrome. Sorry. So this is your esophagus, right? This thing. So what it's saying is, say this thing, there's a enlargement of left atrium. So instead of this, it becomes as big as this, right? So what's it gonna now do? It's gonna push onto this esophagus, right? So what does esophagus do? It travels. It's your food passage, right? So if something's pushing against it, you're gonna have a hard time swallowing. So that's why it causes dysphagia. And there's also, remember, there was a left recurrent laryngeal right there, because this is aorta, and then it goes from here, from the right side to the left side, like that, right? The aortic arch, I got that, like that. the aortic arch right there, and the aortic arch has left recurrent laryngeal nerve, so that's gonna do that other color. Right. So aortic arch, so that's also gonna get affected right there, I guess, because that's where the recurrent laryngeal nerve is. It's around the sixth one, or the PDA. Okay, so right ventricle is the most anterior part of the heart. Okay, again, that's the one that touches your chest wall or thoracic wall. Uh, right ventricle is the most anterior part of the heart and most commonly injured in trauma. They will test you on this, so remember, this is the most posterior part. Okay. Then you have right ventricle is the most anterior part of the heart and the most commonly injured in trauma. So if someone gets punched in the chest, this is the one that gets damaged first because it's the closest one to the wall. Left ventricle is about 2/3 and right ventricle is about 1/3 of the inferior diaphragmatic cardiac surface. Okay, so left ventricle is about 2/3 and right ventricle is about 1/3 of the inferior. Right, so on the bottom, so this is the bottom right here, and this is your diaphragm from here to here. Right, so that's your diaphragm. So the surface of the heart that's touching this diaphragm, and that's what it's talking about. So left ventricle touches about like 2/3 of it touches the diaphragm, and for right ventricle only 1/3 of it touches the diaphragm and the cardiac surface. Okay, we'll continue this. I believe we were here, pericardium. It consists of 3 layers from outer to inner. So it has fibrous pericardium on the outside, then the parietal pericardium, and then on the inside you have epicardium, visceral pericardium. Right. So that's the fibrous on the outside, the parietal and the pericardial over here, and then this is the epicardial or visceral pericardium. You have the coronary vessels on the inside, right between the myocardium and endocardium, and between the myocardium and the epicardium, right? So the pericardium has 2 layers basically, right? With the space, so it has fibrous and the parietal pericardium, right? These 2 layers. On this side, you call that pericardium as well, visceral though, or you can call it epicardium. So between the epicardium and myocardium, you have the coronary vessels, and all the way on the inside of the heart is endocardium. This is the one that would touch the chambers. Okay, so pericardial space lies between the parietal pericardium and epicardium, right? This and this. And pericardium innervated by phrenic nerve. This is important. Why? This is the reason why if you do have a heart attack or something, people feel pain in the arm, because phrenic nerve goes from the diaphragm to the shoulders, if you remember the dermatomes. Then you have pericarditis. It can cause referred pain to the neck, arm, and or one or both the shoulders. Often it's the left side. Okay. Coronary blood supply. So out of these, you need to know these 3 at least, and then all the other ones are just there. Okay, so coronary supply. Okay. Left anterior descending, so that would be this one right here. Okay, so when you think of this, think of it like on your own self looking down at the heart, and then it will be easier to think about it. So this would be on the anterior side, right? If you hold your arm out in an anatomical position for the heart, and then just follow it with the finger. So this is the anterior, left anterior descending artery. Okay, and then right. So LAD and its branches supply anterior 2/3 of the interventricular septum. This is important 2/3 on the top. Basically, on the inferior side, it's going to be this inferior or posterior side, right? So that's what that is. So anterior 2/3. So see, this is the septum. So it's going to be uh, if this is the septum, it's going to be this area. So 2/3 of that area. So I guess that much is supplied by LED, right? Anterolateral papillary muscle is supplied by that too. Uh, those are the ones that support the valves, right? So it's the one that looks like this around the valves. So these are like your papillary muscles around the valves. Anterolateral papillary muscles and anterior surface of the left ventricle. So that's easy. Most commonly occluded, right? So when they have ischemia or something, it's going to be this artery. That's the most common artery that gets occluded. Then you have PDA, which is posterior descending posterior 1/3 of the interventricular septum. So if you're still in your anatomical position with your hand, you just pull it out a little forward and then you can see the back of the heart. So the back of the heart is going to look like this. Now your thumb's going to be on that side, and then you have your arm coming in with the pinky here and your middle finger here and like that, and like your thumbs like that. Okay, very demented hand. But yeah, so on the pinky side you have the PDA, posterior descending artery, right? So it supplies the posterior 1/3. So that's this 1/3. Okay, so now the interventricular septum is like this on this side, right? So now it's going to be the bottom part. It's going to be this bottom part right here. Sorry about that. Or that bottom part that's not covered. Okay, so it supplies the posterior 1/3 of the interventricular septum, posterior 2/3 of the 2/3 wall of ventricles, right? Okay, so the ventricle itself, its walls, it's going to supply, and posteromedial papillary muscle. So this one also supplies the valve muscles. Okay, the posterior medial ones. So this is the posterior medial, and this is the anterolateral. So it's important to know this difference because they might give you like I don't think they'll give you an ECG, but if you have to figure it out from an ECG or something, or they'll just tell you that there's an occlusion in the anterolateral part, so which artery is it and what other structures can get affected, then you need to know that's like PDA, and the structures that get affected are the posterior medial papillary muscles, 1/3 of the interventricular septum, and the posterior walls of ventricle, around 2/3 of it. Yeah, right, so like that. Right coronary artery supplies the AV node and SA node. That's important. Okay. Infract may cause nodal dysfunction. So if there is a thrombus in there or an infarct or something around this area, that will cause decrease in supply to AV and SA node, and that will cause nodal dysfunction. So then if that happens, you get bradycardia or heart block, right? The right acute marginal artery supplies the right ventricle. Okay, that's this one, anterior marginal artery. Okay. Yeah, so that comes from the RCA, which is the right coronary artery. Okay, so don't confuse your cornea with carotids and cerebral arteries. Okay, so RCA is for right coronary artery in the heart. Okay, so EMA. Again, this is on the, if you still have your hand out as an anatomical position and put it like that, it's on the side of your thumb. So where your thumb is, that's where that would be. Okay, because your thumb would be right here. So, okay. Bradycardia, that about covers that. Now, sometimes this artery right here, it can get supplied by this one instead of this one. Okay, so we'll read about that. So dominance, right dominant circulation, most common. So most people will have this kind of circulation. So PDA arises from RCA. Sorry, I meant this instead of this can get from that. Okay, so PDA. So that again, this is posterior descending artery. Okay, it's on the back side. This would be like right above your pinky here, so right there. Then you have, yeah, so this one is coming from orange, and the orange one's right here. So if you look at it that way, this orange will go keep on going, and then you turn it around. If you flip this, it's gonna be like this, and then the orange comes in with the PDA, right? And there's also left dominant circulation, right? So they might tell you that they checked the patency of RCA and it was clear, but then there is PDA that got occluded. So how is that possible? It's possible because the PDA here is getting supplied by the left dominant circulation or the left circumflex artery. So LCX is the circumflex artery. So that's this one right here. So LCX is this thing right here, the green, and that comes from. If you flip this over, it's right here. So LCX is coming from the left coronary artery, right? So the pink one. So the pink one is coming from here, from the, I guess, origin of the aorta to travels at the border of left atrium, and then it goes behind the left atrium, and then that's where the left circumflex artery can turn into posterior descending artery in some people. And then you have obtuse marginal artery. So that's this thing right here. That's just another name you have to remember, but they would ask you about that. What you have to remember is left circumflex artery. Okay, so if a thrombus was to come over here, how is it going to travel? It's going to travel from coronary sinus to or whatever supplies this. Left carotid artery to left circumflex to posterior descending, or it can come from right coronary artery and go straight into PDA, posterior descending artery. Right? And then there's there's some people who have both of the circulations. So they have PDA arises from both left circumflex artery and the right coronary artery. Okay. Coronary blood flow. Okay, so if you weren't aware of what I meant by anatomical position. No one's holding it up. Yeah, that's the anatomical position of the heart right there, right? So that's how you would hold it. So just pretend like you're holding it like that, and then the thumb part would be the anterior and the pinky would be the posterior. Okay, then you have coronary blood supply from the left ventricle, so that's where it comes from. Left ventricle and interventricular septum peaks in early diastole. Okay, sorry, never mind. So coronary blood flow to left ventricle and interventricular septum peaks in early diastole, and coronary sinus runs in the left AV groove and drains into the right atrium. Okay, both of these things are important. So what it means is, let's see, when the say the heart starts pumping, right? So when it pumps, what happens is it's using up all its energy, and all the energy it uses up, the muscles are going to require what? It's going to require blood that's oxygenated, right? So all the blood gets, and there's increase in resistance because it's contracting as well, right? So that's why when it relaxes and or it's in diastole, in ventricles, that's when the resistance decreases and the blood flows to uh, through the coronary vessels, right? So coronary blood flow to left ventricle and interventricular septum peaks in early diastole. This is also the time when it's gonna be the most oxygenated you're gonna find in coronary blood flow, because when it goes into systole, all the blood becomes deoxygenated right away, and that's why coronary sinus contains most deoxygenated blood in the body. Okay, because it gets used up by the heart right away. So there is a question, and that's me telling you the answer for it. So they're gonna have, okay, so which part of the body contains the most deoxygenated blood during systole? During diastole or systole, one or the other, and then they're gonna give you option like the brain, the kidney, medulla, uh, splenic flexure, stuff like that, to make you think it's a watershed question, but it's not. It's a heart that uses the maximum amount of oxygenated blood. Okay, and then you have coronary sinus run in the left AV groove. You need to know this location because they will ask you this, and they'll be like, okay, so where does coronary sinus drain? Right, it drains into right atrium. Okay, so right there it would drain. Okay, so let's get rid of all of this. Okay, so remember, right atrium has the right coronary artery, left atrium has the left coronary artery. Right atrium goes into the back and then turns into posterior, posterior descending artery. Left coronary artery goes around the left atrium as left circumflex artery, and then it could turn into the posterior descending artery. But RNR is the most common one. Sorry, PDA, RP. So RCA and PDA is the most common one. It could be that it's both of this, or it could be just the left. Uh, the bottom of, okay, so what it supplies is left anterior descending artery supplies the anterior 2/3 of the interventricular septum, the anterior side of the left ventricle, and the anterolateral part of the papillary muscle. Okay, the posterior descending artery does the posterior side of the interventricular septum, 1/3 of it, the posterior wall of the ventricles, 2/3 of it, and posterior medial papillary muscles, right? And then you have right coronary artery, the most important one, which supplies the AV and SA node. Infarct may cause nodal dysfunction, bradycardia, heart block, and then you have right acute marginal artery supplying the right ventricle. Okay. Now we're on to physiology. Cardiac output variables. Stroke volume. Stroke volume is affected by the contractility, afterload, and preload, right? So increase in stroke volume is caused by increase in contractility, for example, anxiety or exercise. Increase in preload is, for example, is in early pregnancy, right? Because remember, blood volume increases. And then decrease in afterload also causes increase in stroke volume. Okay, so this is basically how much is left over after systole, right? Or that. Then you have that's how you remember it. Stroke volume affected by contractility after load and preload. Okay. Failing heart has decreased stroke volume. So systolic and or diastolic dysfunction, right? Because a failing heart would have what? Decrease in contractility. So that would decrease in this. So if we were to put it into a formula, that would be SV equals contractility and preload over afterload, right? So, because I guess it would be times here. So, if contractility goes up, stroke volume goes up. If preload goes up, stroke volume goes up, because there's more to go give in cardiac output, right? Even contractility will help with the cardiac output. What won't help is like if this goes up, this goes down, right? So afterload goes up when there is oh, it's raining outside here. Cool. When there's leftover fluid after the systole, right? So if there's leftover fluid, that means that much fluid didn't add to the cardiac output, so stroke volume is lowered, right? So you can think of it that way. Okay. Contractility. So there are certain things that can increase and decrease it. So which ones increases it is contractility and stroke volume increases with catecholamine stimulation of beta 1 receptor. Remember, beta 1 is the heart one, and it increases heart rate, contractility, increases renin production as well, right? So activated protein kinase A. Okay. So phosphorylation, active calcium ATPase increases in calcium storage in sarcoplasmic reticulum. Remember that from biochem, I think. But similar concept here too. Yeah, I'm not gonna be able to find it right now, but I hope you remember that one. Okay. And then you have activated protein kinase A, which increases calcium. Remember the GS protein and all that? That's what I was talking about. That's what that is. Increase in calcium storage in the sarcoplasmic reticulum. So activated protein kinase A, calcium channel phosphorylation, increase in calcium entry, increase in calcium induced calcium release. Okay. Again, calcium is the most important ion for heart because this is the one that causes contractility, right? And heart has its own supply of calcium intracellularly, unlike the other ones where calcium needs to come from outside. But in heart, they have a vesicle that contains calcium and it has receptors on it. So those receptor gets depolarized by sodium. So to say increase the amount of calcium intracellularly, we give digoxin, right? So what does digoxin do? Digoxin blocks that channel, the sodium potassium pump. Potassium always goes out and sodium comes in, right? So when you block it, what happens? Sodium stays inside the cell. I hope you're following this. So see, this is the cell, and then you have one that contains calcium, right? So this contains calcium, right? And these vesicles have calcium receptors here, and then you have Na coming in through the sodium potassium channel, and sodium potassium. So potassium's gonna go out, and sodium's gonna and A just I'll just write Na comes in, okay, and then potassium goes out. So when you give digoxin, it blocks this pump, right? It blocks that pump. So what happens? The sodium you have inside is not going to be able to go out, okay? It blocks the active channels, so it can leave through like passive ones, but there's so much that's going to be negligible difference. So as long as there's sodium inside, it's going to keep attaching to this and keep the calcium coming out for longer times, and that causes increase in contractility. That's why we give digoxin. Okay, that's why calcium is really important for heart. Uh, and this vesicles that I said, it's sarcoplasmic reticulum. Okay, so that's what that is. So we give catecholamines to increase storage of this, so this becomes bigger, so you can fit more calcium in it. And hold on, I got a message. Oh, thanks. Yeah. Okay. So someone sent my own notes to me, and I appreciate that. Let me send it here. So this thing, the GS protein, GI protein. So this is where the sarcoplasmic reticulums are, right? So through the whole this thing, and the depolarization actually happens because of sodium. So you just end up with this. So with this thing, uh, calcium from the sarcoplasmic reticulum then gets activated. This is it activates protein kinase C, but here we're talking about protein kinase A. That's this one, right? So this is the one that's going to act on it. Again, they both do the same thing. Remember, this also activates calcium. Remember, from biochem, I think, or I don't know. I remember right now, but yeah. So this thing will go on to. This thing goes on to activate calcium release from intracellular sarcoplasmic reticulum as well. Okay, this one inhibits this. Okay, the GI one, but this one activates it. Okay, so activated protein kinase A, calcium channel phosphorylation happens, calcium enters, and you have increase in calcium induced calcium release. So you have intracellular calcium increase and decrease in extracellular sodium, right? That's this whole thing I just said. So when you have decreased extracellular sodium, that means there's more intracellular. So there's decrease in activity of sodium calcium exchanger as well. Okay. Digoxin. So it blocks the sodium potassium. Okay, they gave it here. Digoxin. It blocks the sodium potassium pump. So you have increased intracellular sodium. So decrease in sodium calcium exchanger activity, right? So okay, so when I said that, they also exchange for calcium. So calcium will come in through this, and sodium. Sorry, no, I said the opposite. So sodium comes in and calcium goes out. Okay, that also happens. So there's calcium coming from outside as well as inside, I guess. Okay, so oh, no. Okay, I got it. It's not this, it's this one. It's talking about this one. So increase in intracellular sodium, so there's decrease in sodium calcium exchange activity. So okay, so when they block digoxin blocks this as well. It blocks this and it blocks this, I guess. No. Okay, forget everything I said after I made sense and I stopped making sense, so don't listen to me when I start making sense, okay? I'm confusing myself now. So increase in intracellular sodium will cause decrease in sodium calcium exchange activity, which increases this. This is the main thing you gotta remember. There's increase in intracellular calcium, and intracellular calcium causes contraction. We'll do that in musculo, but there's like myosin and all that stuff, right? Troponin C and all that stuff that does the contractile. It's similar to that. Okay. Then you have contractility and stroke volume decrease with. So these are the ones that decrease the stroke volume. Okay. So you have beta 1 blockade. So if beta 1 is responsible for increasing heart rate, increasing contractility, increase in renin, and there was a third thing I don't remember. Uh, but so if you block that, what's going to happen? Heart rate will go down, uh, contractility will go down. So if that goes down, stroke volume goes down. Heart failure with systolic dysfunction, acidosis, hypoxia, hypercapnia, a decrease in PO2, increase in PCO2. Okay, so hypoxia, hypercapnia. Then you have non-hydro pyridine calcium channel blockers. Okay, we'll learn about this in the pharmac section of CVS. Okay, so when you have decrease in oxygen, okay, this is an important concept too, because remember up here we just talked about coronary vessels. They require oxygen to function and to have left ventricle contract. So if you don't have oxygen, there won't be ATP. If there's no ATP, there won't be any contraction happening, because in that whole complex of troponin, myosin, and all that, you need ATP for contraction to happen, right? And you need oxygen for that as well, because oxygen goes into the uh, electron transport chain into the mitochondria, and mitochondria makes ATP. Okay. Uh, so when that's decreased, you won't have contraction, so that will decrease contractility, thus decreasing stroke volume. Okay. Acidosis, just remember that. They won't test you on CVS for acidosis, they'll test you on renal and respi, mostly for that. Okay, so heart failure with systolic dysfunction. Again, heart failure is what? It could be compensated or decompensated, right? If there's systolic dysfunction, that means it's decompensated, and that will cause decrease in contractility. In compensated, their contractility ejection fraction is preserved, and decompensated, it's, it can't compensate for the loss of that. Okay. Preload approximated by ventricular end diastolic volume. Depends on venous tone and circulating blood. Okay, so end of diastole, right? So what is diastole? Again, this is your left atrium, this is your left ventricle. Okay, so is the amount of blood when this relaxes, right? So when this relaxes, the aortic valve closes and the mitral valve right here will open, and when that opens, the blood from left atrium will go into left ventricle, and this process is known as the diastole. So the amount of blood that comes in here is known as preload. Okay, so everyone has preload and it's normal. The only time it's not normal is right here. So preload, approximately that. It depends on the venous tone. So if the venous tone is low or the circulating blood is low, right? So the blood that's coming in, the venous return is low, then this blood going in here will be lower. It could be that there's also in aging, I think. I'm not sure. We'll do the changes in age. I forgot. That will lower up the cavity as well. Hypertrophic cardiomyopathy might also lower it. We'll see. I'm not sure. Don't quote me on that just yet. But just understand what preload is, right? So it's the blood coming in. If the blood coming in is lowered, preload will be lower. If the blood coming in is higher, like in pregnancy, blood volume increases, so preload will be increased in that. Okay. So it depends on venous tone and circulating blood volume. Vasodilators, right? So vasodilators are going to do what? They're going to dilate the systemic vessels, right? So when that dilates, the blood starts pooling in at least the veins, right? Because they don't have the valves. So when they start pulling there, what's going to happen to the venous return into the inferior vena cava, right? Just imagine this RA now. Right atrium, this whole thing. So this is going to decrease, right? Because now it's pooling in the veins. So if the blood coming in is decreased, it's gonna do what? Decrease your preload, right? So nitroglycerin, this is important. We give this in heart failure as well, because in compensated heart failure, you'll have basically hypertension or increase in blood volume. That and since your heart is already working overtime, you don't want to increase the workload. So for that, we decrease the workload by giving them nitroglycerin. Okay, heart load, afterload. Sorry. Uh, what is afterload? So afterload approximated by mean arterial pressure. So what happened? Let me start again. Okay, just ignore that part. Okay, so mean arterial pressure, just so you know the formula. I don't know, have they given it? I don't want to end up doing a formula and then they give it. Okay, so that's what it is right there. It's 2. Okay, I don't like how they wrote it, so I'll write it out. So, MAP, MAP equals systolic volume plus 2 was it 2? Yeah, 2 diastolic volume. Let me just confirm I'm not giving you a wrong one. Yeah, and it's all divided by 3. All divided by 3 because there are 3 values, right? So this is what they wrote. So they wrote 1 over 3 for systolic and 2 over 3 for diastolic, I think. 2 over 3 for diastolic plus 1 over 3 for systolic, right? So I write it like this because it's easier to comprehend for me. So systolic plus 2 diastolic divided by 3 gives you mean arterial pressure. Know this formula because it could come in handy if they're asking a question for this. So afterload, again, afterload approximated by MAP. Okay, so mean arterial pressure. Increase in wall tension per Laplace's law, increase in pressure, and increase in afterload. So LV compensates for increase in afterload by thickening hypertrophy in order to decrease wall stress. Okay. So left ventricle compensates for increase in afterload by thickening or hypertrophy in order to decrease wall stress. Okay. So when I say what's left over, that's not ideally what you should be thinking of. So what is wall stress? So say this is your left ventricle, okay? And it's like that, okay? And then when blood comes in and it's all end of diastolic, right? After end of diastolic, what happens? The coronary artery is going to supply the oxygen to the muscles of this left ventricle. It's going to use up, and then it's going to contract. So when the contraction happens, so think of it like a link, like this, like that, right, and then like that, similarly. So the muscle fibers will link up to each other, and when that contraction happens, all this will get pulled in together, right? So when that gets pulled in, this goes inwards, right? This goes inwards, so that all the blood can go through the aorta over here, and through the aorta, right? So that's contraction. So the amount of wall stress it takes in, or the muscle fibers they're in, the amount of work it can do is what the afterload is based on. So if it can't take in that much stress from the blood, basically, then the afterload will increase. If it's nothing for it, it's like, oh, dude, I can just do this in my sleep kind of thing and just push the blood out the aorta. That means there's not going to be any afterload. Okay. So It's the increase in wall tension. So wall tension happens when the muscle fibers, something's wrong with those. Okay, so increase in wall tension, per Laplace law, increases pressure. Okay, and this increase in pressure will increase afterload. Okay, so what can happen to this? It can get fibros due to ischemia or something like that. Like, MI. So LV compensates for increase in afterload by thickening or hypertrophy. Okay, so now that these muscles are not able to, uh, you know, pick up the pressure from the blood inside or pick up the load, what's it going to happen? These things are going to get trophied. And remember, trophy, you like them big, so hypertrophy means bigger cells. It doesn't mean cells get multiplied. That's hyperplasia. Don't confuse that. Okay, so see, this muscle fiber is now going to get hypertrophy like that and like that. Right, the muscle fibers are now from that to this. So and you can imagine you have like hundreds and thousands of these in your heart, and if they all get big like this, what's going to happen to this border? It's going to get bigger, right? Like that. So that's called hypertrophy. In hypertrophy, I guess the cavity stays the same, but it's going to be just this side. This side is going to stay smaller. It doesn't affect the interventricular septum because they don't push the blood. What pushes is these fibers right here, so these are the ones that are going to get big. Okay. This is a important distinction because this is how you're going to distinct it from a hereditary hypertrophic cardiomyopathy to hypertrophy of right and left ventricle. Okay, this is it. In the hereditary one, the interventricular septum and the left ventricle, they both get big. Okay. Hopefully that clears that up. Left ventricle compensates for increase in afterload by thickening or hypertrophy in order to decrease the wall stress, so it can handle this. Arterial vasodilators. Also, if there's increased systemic resistance, that's also gonna increase your afterload. I don't have to give that here, because then this has to work harder, right, to get the blood flowing outside. So to do that, because the vessels are now a little smaller, because of the systemic vascular resistance increase, so that means the heart has to work harder. So that will also create increase of myocardial cells. Okay, so atrial vasodilators, for example, hydralazine, decreases afterload. So what do these do? This is a hypertensive drug, right? So it's gonna decrease the systemic vascular resistance. So if that is decreased, my bad. If that is decreased, what happens? Again, this one doesn't have to work as hard now, so it will decrease the afterload. ACE inhibitors and ARBs decrease both preload and afterload, right? Angiotensin converting enzyme inhibitors, because this also causes vasocontraction, right? Angiotensin receptor blockers. So if you don't have angiotensin 2, right? Angiotensin 2 is a vasoconstrictor, so you're going to block that. So that will also cause decrease in both preload, because there's going to be decrease in venous return, and afterload, because there's going to be decrease in systemic resistance. Chronic hypertension, increase in MAP, will cause LV hypertrophy. Again, this is MAP, systolic plus 2 diastolic divided by 3. So if or you can just think of it like, so in chronic hypertension, what happens? Again, this is a different concept than this, but similar. So in a vessel, right, say this is a vessel, and you constantly have blood flowing through it, right? And the blood is now getting increased. It's pushing harder and harder. And then the vessel now, remember, vessels also have muscles in them. They're called what? Intima, medial, and external, right? So it has three layers. Let me go into that. Okay, so it's called tunica intima, tunica media, and tunica externa. And just like any muscles exercising, uh, if there's a lot of pressure coming to it, it's gonna get hypertrophied, right? So that's what happens to vessels as well. So uh, when these get bigger, what's gonna happen to the vessel? The systemic resistance get bigger as well. At first, it's gonna take all the pressure because it doesn't have the muscles to fight it, but eventually it's gonna grow muscles, and then it's gonna increase the systemic resistance. So when this, no, we don't need that now. So when we have this, there is an increase in systemic resistance. Uh, what happens to the afterload? It increases. What happens after there's increase in afterload? Uh, there is increase in wall stress. So increase in wall stress will then the LV will compensate for it by making its cells bigger, so hypertrophy. So that's why you have left ventricular hypertrophy because of that. Okay. And I keep doing that. Make it smaller and black. Cardiac oxygen demand. Myocardial oxygen demand is increased by increase in contractility. That should make sense now. Increase in afterload proportional to the arterial pressure. That should make sense now. Increase in heart rate. Okay, we didn't do it, but we sort of did it. Right. Increase in diameter of the ventricle. So that will also increase wall tension, and this happens in during decompensated heart or dilated cardiomyopathy, right? So when you have dilated cardiomyopathy, that will increase wall's tension as well because now it's trying its best, but it can't, contract to the same diameter it used to. Okay, so all of this will increase oxygen demand. Coronary sinus contains most deoxygenated blood in body. Okay, there you go. So this, I guess I wrote it up there, but this is important here. Coronary sinus contains most oxygenated blood in body. There will be like a question on it, and now you know what the answer is. Wall tension follows Laplace law. So wall tension equals pressure times the radius. The bigger the radius, the bigger the wall tension. That's why increase in diameter of ventricle has increase in oxygen demand. Increase in pressure also increases wall tension. That's why we have increase in afterload causing hypertrophy as well, right? So wall stress is proportional to pressure times radius divided by 2 times the wall thickness. Okay. These formulas not really that important. Just know what the Laplace law is, or even if you don't know, just know the physics that I just taught you, and you'll be good. Cardiac output equations, equation and notes. Okay, so now we're doing stroke volume equations for all of these. So stroke volume is equal to end diastolic volume, that's the ventricle filled up to the brim, minus end systolic volume, that's the empty ventricles to the bottom, right? So how much is it filled minus how much is left over is what your stroke volume is. So yeah, so you can imagine if the leftover is more, then you have a decreased stroke volume, right? Because that's a bigger minus than a minus number or a number you're subtracting is bigger, right? If you have a higher end diastolic volume but a zero end systolic volume, then you can imagine stroke volume being increased because cardiac output is increased now, kind of like that. Okay, because remember, cardiac output is equal to stroke volume times heart rate. So if stroke volume is increased, cardiac output is increased. These two are attached to each other. Similarly, in 1 minute, say a person has a heart rate of 60 compared to a person who has a heart rate of 80. So the 81 has an increase in cardiac output than the one that has 60, right? So like that. So stroke volume equals EDV minus ESV, and systolic volume. Ejection fraction. Ejection fraction is systolic volume divided by end diastolic volume. Okay. Which is equal to end diastolic volume minus end systolic volume divided by, again, end diastolic volume. So ejection fraction is an index of ventricular contractility, decrease in systolic heart failure, usually normal in diastolic heart failure. Okay. So this is important because this is how you're going to differentiate between compensated and decompensated heart failure. Okay. That's the only time this is going to be important anyways. So ejection fraction normally is around like 55 to 65, I think. So anything lower than that would be like decompensated. Okay, so ejection fraction is an index of ventricular contractility. That's what it determines. Okay, so a decrease in systolic heart failure. So systolic heart failure, what is that? It's when left ventricle can't push, right? It can't push the blood out. That's the systolic heart failure. So if that can happen, then stroke volume is going to be lower, right? If a stroke volume is lower, then cardiac output is lower. Cardiac output is lower. That's a heart failure. Right? Why is it normal in diastolic heart failure? That's a filling problem, right? It's not a whatever is filled in. The left ventricle can still push it out. Whatever is filled in. So ejection fraction is preserved there. That's what it means when I say EF is preserved. I'll just say EF because for some reason I feel like this is a tongue twister for myself. So EF is preserved in diastolic because left ventricle is still functioning, right? To like, it can push out blood. It's just the diastolic heart failure. So the blood coming in is the problem. Maybe it's not enough blood coming in, or too much blood coming in, or something like that. Because diastolic is depend on two things, right? Where'd it go? Preload. So preload approximated by ventricular and diastolic volume depends on venous tone. Yeah, so venous tone and circulating blood volume. So venous tone is like the veins, right? If you have hypertension, then you're gonna have this problem right here. Okay, now you have cardiac output, which is stroke volume times heart rate. Okay, in early stages of exercise, cardiac output maintained by increasing heart rate and increase in stroke volume, and then in later stages, the cardiac output maintained by increase in heart rate only, because stroke volume has plateaued. Like once every single muscle fibril or cardiac muscle fibril is used up, is activated basically. You can't activate more because there are a limited number of cells. So then the stroke volume is going to plateau, right? But you can still increase heart rate. Okay, as they all sync up, there will be increase in heart rate. Okay, sync up. Why? Because of the AV node signals, electrical signals. Okay, so diastole is shortened with increase in heart rate. Okay, because if it's beating so fast, there's not enough time for it to fill up. So again, this is the ventricle, and then this is your atrium, like an ice cream cone. So if this keeps on beating really fast, like boom, 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 what's gonna happen to the feeling? It's gonna be, before it's even like filled up, touches the bottom, it's gonna get pushed out the aorta, right? Again, fill up, pushed out the aorta, fill up a little, push out the aorta. So the filling is decreased now compared to when it was normal. it would fill up for like a whole half a second or whatever, and then get pushed out, right? But at this point, it's beating so fast that it's really low and then gets pushed out. Okay, so diastole is shortened because of that when there's increase in heart rate. For example, ventricular tachycardia. So there will be decrease in diastolic filling time, which decreases stroke volume, right? It affects stroke volume because cardiac output is lower too now. There's less blood going out. Pulse pressure. Pulse pressure is systolic blood pressure minus diastolic blood pressure, right? So it's basically, say you have 135 systolic and you have like 89 or just 90 diastolic. And then you take the systolic, subtract the diastolic from it. So that would be, say this is the baseline. This is diastolic, this is systolic number. So you, at this point, I'm just teaching you math for some reason. Yeah, so when you take that out, this part is what's left over, and that's called the pulse pressure. Why is this important? Because pulse pressure, they'll probably tell you. Pulse pressure is directly proportional to stroke volume and inversely proportional to the arterial compliance. Okay. So what that means is, what's better, if pulse pressure is higher or lower? Higher is bad, lower is bad as well. They both are bad. It should stay normal, within the normal range, which is what? So 120 minus 80, that's the normal. So increase in pulse pressure in hyperthyroidism, aortic regurgitation, aortic stiffening, isolated systolic hypertension in older adults, obstructive sleep apnea, increase in sympathetic tone, anemia, exercise transient. That's just transient. So pulse pressure decreases between these two, right? Because increases between the two, because diastolic is going to be decreased, preload will decrease, but heart rate and contractility increases. So systolic blood pressure will be much higher than diastolic, so this will be much lower and this will be much higher. So this thing. This will be much higher, right? Okay. Increase in pulse pressure. Okay. How much time do we have? 3 minutes. Okay, let's just take a break here. And we'll come back. Okay, let me finish this pulse pressure actually. Okay, so increase in pulse pressure in hyperthyroidism, aortic regurgitation, aortic stiffening, isolated systolic hypertension in older adults, obstructive sleep apnea, increase in sympathetic tone, anemia, and exercise transient. The decrease in pulse pressure happens in aortic stenosis, right? Cardiogenic shock and cardiac tamponade, and advanced heart failure. So aortic stenosis is when LV can't put out the blood into aorta fast enough because the aortic valve is stenosed, so it's blocking it, it's obstructing it, so it has to increase the pressure to push it out, kind of thing. The systolic blood pressure will be decreased in aortic stenosis, so it's going to be closer to the diastolic blood pressure. Sorry. Cardiogenic shock, that's just your heart muscles not functioning properly. Cardiac tamponade, that's the pericardial space has fluid, so it's pushing in pressure into the epicardium and then myocardium and into the myocardium, right? So that's what that is. It increases the diastolic volume, I guess. Okay, and lowers the systolic volume, blood pressure. Sorry, not volume. And then you have advanced heart failure. We already discussed that. So that takes care of the pulse pressure. Okay, we'll come back after the break. So they will give you a question with by telling you that the venous return oxygen content is like, say, 5%, and then arterial oxygen content is like 98% or something, right? So then you have to figure out what this number is, and they'll give you the rate of oxygen consumption, right? They'll give you all these three things, and then they'll ask you what is the cardiac output or something like that. So you have to remember that we have a formula for that. So the formula for that is rate of consumption goes up, and then you figure out how much oxygen is, used up basically from the time it left ventricle and by the time it returned to the right atrium. Okay, and so that number will go down here, and then you can figure out cardiac output with that. Another way is stroke volume and heart rate. Q is the flow, I think. But okay, so Starling curves. Here we have stroke volume. Here we have ventricular end diastolic volume on the x-axis, so that's going this way. So the higher number will be here. So this is the normal preload, and here it's decreased, and here it's increased, right? And then this is the normal stroke volume. The stroke volume here is increased. Here it's decreased, but it's higher than here. That's also decreased, right? So Starling curve. So force of contraction is proportional to the end diastolic length of cardiac muscle fiber, right? So say you have a balloon, right? So you have a balloon and you fill it up. So a balloon that was this small, and then you fill up fluid inside, and then it's gonna grow into this thing, right? It's gonna grow into this. So now you have blood all over in here. Okay, so this thing is gonna push onto this layer, or fluid that's gonna push onto the layer of the balloon. Okay, and now the recoil. Heart has the recoil muscles or the contractile muscles, right? So the more you push outwards, the more it's gonna push inwards, right? The more you push outwards, the more it's gonna push inwards. So that's what they're talking about. The force of contraction is proportional to the end diastolic length of cardiac muscle fibers. So those muscle fibers, if this increases, they will stretch more. So when they do go into contraction, that's how much work is increased, and they'll contract more, right? So more fluid, more contraction. So it's proportional to the preload and the thing. Okay. Increase in contractility with catecholamines, positive ionotropes, that's dobutamine, milrinone, digoxin. Okay. Some way or another, they'll increase calcium. Okay. In the intracellular. Decrease in contractility with loss of functional myocardium, for example, MI, beta blockers acutely, non-dihydropyridine, calcium channel blockers, and heart failure. So again, this thing we know is heart rate, contractility, and renin. Remember, renin's not appropriate here, but it's just so you don't forget that it has action on that as well. So beta blocker will decrease the contractility, we know that. With loss of functional myocardium, right? So, for example, MI, right? If these are fibros, this fiber right here, that's not going to function, so you're going to have decrease in contractility. Non-dihydropyridine calcium channel blockers, these are the ones that act on the heart, and they stop the calcium receptors. I forgot where it was. These things right here. So calcium don't come out. Okay, so I think that's what it is, but we'll check it out in farm after. Okay, resistance, pressure, and flow. Now volumetric flow rate, Q. So that's cardiac output is equal to this. Okay. So Q equals to flow velocity times cross-sectional area. Okay, so what that actually means is just, how much, if the cross-sectional area is increased, or like a big one like that, you're gonna have a bigger flow rate. If the cross-sectional is decreased, like this one is gonna have lower flow rate than a vessel that's this big, right? Because there's gonna flow more, so that's what it is. So that's the cross-sectional area and the flow velocity. So even if it's small but high flow, then you're gonna have more flow rate. Whereas if you have a big one but a small, really slow flow rate, then that's gonna decrease it as well. So it depends on both of these things. Resistance, driving pressure, or delta P over Q, and you have whatever this is times length, viscosity times length divided by pi r to the power of 4. Okay. In this formula, you need to remember this thing, that it's resistance divided by r, pi r to the power of 4. So whatever you have, you gotta, I think you have to do it times by itself 4 times, or they'll give you a radius, and then you radius is going to be like 2 mm or something, right? And then you multiply it by itself 4 times, or 2 to the power 4, you would get 16. And usually that's the answer. That's going to be always the answer, because they only pick those two numbers when they're asking about resistance. So they'll ask you, there's a artery and it was clamped halfway, so only 50% of it was open or something, right? So when you decrease the thing, resistance increases. So if resistance increases, the radius has decreased, right? So when the radius decreases, they're going to ask you how much of it was decreased or something. So it's going to be 16 times lower, kind of thing. Okay. So if length increases, resistance increases, right? If length decreases, resistance decreases. Viscosity increases, resistance increases. Viscosity decreases, resistance decreases. For this question, if you find a question on UWorld, you can share it on the group and we'll go through it if you don't understand it. Yeah. Okay. But remember, you have to get to 16, so just plug in the formula and you'll reach there. All of this stuff doesn't matter because they don't test you on it. They test you on your knowledge on the radius. If they clamp it down by this much, how much resistance is increased by? So it's increased by 16 if it's half. Okay, so total resistance of vessel and series. Okay, so if it's in series, the length is going to be increased, right? So if you add R1 length to the R2 length to the R3 length, it's going to keep increasing, right? Because again, length and resistance is proportional. But what if the length is divided? So now this length of whatever flow was going through this R1 is now split into 3, right? So now it's 1 over R1, 1 over R2, and 1 over R3. So that means what? It's decreased. Resistance is decreased, right? And this is what happens in capillaries and reticular network of vessels, right? Flow is proportional to the R4. Resistance is proportional to 1 over R4, right? So if you increase the radius or diameter, you increase the flow. If you decrease the diameter or radius, you increase the resistance. Okay. Capillaries have highest total cross-sectional area and lowest flow velocity, right? Because again, capillaries split the vessel up, so the resistance is going to be low. If there's a blockage here, it's just gonna flow into this one and into this one. It's not gonna, if unless there's a blockage here, then it's gonna back up and increase pressure and resistance. So that's how that works. Pressure gradient drives flow from high pressure to low pressure. So if there was here, then this is high pressure, so this blood goes into the low pressure one, kind of like that. Arterioles account for most of the total peripheral resistance. Okay, veins provide most of the blood storage capacity. This is why venous return decreases when you give them vasodilators. Viscosity depends mostly on hematocrit, right? The more hematocrit, the increase in viscosity. Viscosity increases in hyperproteinemic states, for example, multiple myeloma, polycythemia, and then viscosity decreases in anemia. Cardiac and vascular function. So this is the cardiac function curve. You have cardiac output and venous return on this side, in red and blue, and then you have the right atrium pressure. Similar here and similar here. So first graph is about inotropes. So effect is change in contractility, increases in altered stroke volume, altered cardiac output and venous return, and right atrium pressure. So when you have a cardiac function like this and decrease in inotropy, it goes down and cardiac output, and if you increase inotropy, then it contractility basically increases, so cardiac output increases. But the venous return stays the same, and this is your mean systemic pressure. Okay. So for example, for this curve, you give catecholamines, dobutamine, milrinone, digoxin, or exercise even, right? They all increase cardiac output. But say you have heart failure with reduced ejection fraction, so decompensated heart failure, narcotic overdose, or sympathetic inhibition inhibitor, negative? I don't know. Okay, so anyways, but it makes sense that the cardiac output will go down, right? So inotropy is decreased. Then you have venous return. Okay, on this one, so changes in circulating volume, altered right atrium pressure, so altered stroke volume as well, because whatever's coming is what's going to get put out. So change in cardiac output. Okay, so the cardiac output is normalized here, but venous return can increase or decrease according to the volume. So if there's increased volume of venous return, then there's increased volume and venous tone. That's this chart. And then if there's decreased volume and venous tone, then it's this chart. Increased volume happens because of fluid infusion, sympathetic activity, atriovenous shunt. And then for decrease, you have acute hemorrhage and spinal anesthesia. Okay. Acute hemorrhage and spinal anesthesia. Okay. Then you have, because that'll cause vasodilation as well. Okay. Total peripheral resistance. So change in total peripheral resistance, altered cardiac output, change in right atrial pressure. It's unpredictable. Okay. So vasopressors, so vasoconstrictors basically. So 5, if you vasoconstrict, what's going to happen to the cardiac output? There's more systemic resistance in the aorta, so the left ventricle has to push harder, right? So cardiac output is going to be lower because of that resistance. Remember, the left ventricle hasn't acted yet. This chart is showing before there is compensation for that. So increase in vascular resistance would give you this chart. And then 6 is exercise or atriovenous shunt. So exercise increases your cardiac output rate. And then what happens to venous return? To That's unpredictable, right? That's what they're saying. So if total peripheral resistance is decreased, you'll have venous return, but then the preload is also going to be lower. So if preload is lower, cardiac output will be lower, then you would have, you know, decreased venous return. So there's that too. And atriovenous shunt. So that's AV shunt is basically, rather than going through the capillaries, the blood from atria goes straight into the veins uh, without going through the capillaries. That's what AV shunts are. Okay, changes often occur in tandem and may be reinforcing. For example, exercise increase ionotropy and decrease TPR to maximize cardiac output are compensatory. For example, heart failure decrease in ionotropy will lead to fluid retention to increase preload to maintain cardiac output. That's how it tries to compensate for it. Okay, again, maybe report. So exercise in ionotropy and decrease in TPR to maximize cardiac output. That makes sense. Heart failure and decrease in ionotropy will lead to fluid retention. To right, okay. That's basically so in heart failure, this thing is not working. So decrease in ionotropy, the contractility is not that good. So how is it gonna compensate for this when all the whole body needs, blood? So it retains the fluid to increase preload to maintain the cardiac output, right? Because since it can't go out, what it's going to do is it's going to keep this level filled up. So whatever then comes in gets pushed out, and then this much blood will stay in the cavity. But at least that much blood is going to go around and come back, and come back, and then again, same thing happens. So that's how it takes care of that. So at least some blood is flowing rather than none. Pressure volume loops and cardiac cycles. Okay, so let's first go over this. Here you have the mitral valve close. Okay, so let me just draw you guys up. So that's the right ventricle. Thanks. Pretty. Right ventricle. Then left ventricle, then left atrium. This is going to be your aorta. Let's not involve that. Okay. So that's left atrium, right ventricle, left ventricle. Okay. So the mitral valve is over here. Tricuspid valve is here. This is going to be your pulmonary artery, and this is going to be your aorta. So this will be your mitral valve and your tricuspid valve. Okay. Okay. So mitral valve closes. Once diastole happens, this thing closes. So this is end of diastole. Okay. So that's right here. So end of diastole. Mitral valve closes. Then what happens to the pressure inside the left ventricle? It increases. Okay, it increases. The aortic valve hasn't opened up yet, so this keeps on pushing inwards, right? And this keeps on pushing inwards. So until the pressure is built up to the max. So when that happens, it goes all the way up to here, and that's called isovolumetric contraction, right? Once it goes up here, there's enough pressure to open up the aortic valve. So once this opens up, the pressure here starts declining, right? So that's the decline in the pressure and the volume, basically. So we're following the volume here. Okay, so the volume stays the same, but the pressure increases right here. And here, the pressure first increases in the left ventricle, right up to here, and then it's pushing. And since it's pushing through a little tube, the pressure still increases up till here, and then up till here, right? And then it starts declining after each of this, because then you gotta remember this thing comes inwards, right? So then you have this much left ventricle left, and then this much blood going through the aortic valve through that. So until here you have the pressure increase, but the volume is decreasing, right? So that's why it's going in a loop this way. First you had volume up to here, then isometric contraction happened, and then the aortic, enough pressure was there to open up the aortic valve, and when it's opened up, the blood rushes through, and there's a low increase in the pressure as well, but decrease in the left ventricle volume. So it goes this way, and then from here it declines. Okay, so when it reaches this area, there's not enough blood to keep the aortic valve open or the flow, right? So then it closes here. Okay, as this closes, what happens is there's, isovolumetric, because the volume stays the same. That's this right here, right? So this stays almost the same. So that's called isovolumetric relaxation. Okay, so that goes down, and then this is gonna, then you have the mitral valve open up, right? Now there's enough volume, enough pressure in here to be pushed down by the left atrium, because left atrium doesn't have that much pressure. This one has a higher pressure. So when this relaxes, this gets pushed down because there's a lot of pressure in left atrium at this point. So that's going to push down the blood. So mitral valve opens, and when it pushes down the blood, the volume of left ventricle increases, right? So that's what this chart is. Okay. So the black loop represents, I should get rid of all of this now. Hopefully that makes sense. The black loop represents normal cardiac physiology phases. Left ventricle 1, isovolumetric contraction period between mitral valve closing and aortic valve opening. This is the period of highest O2 consumption, right? Coronary arteries are supplying the oxygenated blood, right? So by the time it reaches, the blood from coronary arteries reaches the coronary sinus, it's gonna be fully deoxygenated, right? Okay, so aortic valve, and also it drains into right atrium. So aortic valve opening, period of highest O2 consumption 2. So that was this, and now we're talking about this one. So systolic ejection, period between aortic valve opening and closing. So this opening and closing, so that's number 2. Isovolumetric relaxation, period between aortic valve closing and mitral valve opening. So that much right there. The pressure needs to be almost like, at 20, I guess, to have the mitral valve open. Then you have the rapid filling, so that's this part right here. Period just after mitral valve opening. So the rapid filling is up till like here, and then you have the reduced filling. Now it's gonna, like, after it's filled up, the left atrium is gonna contract as much as it can to fill up the last little bit. So that's reduced filling. So period just before mitral valve closing. Okay. So now let's talk about the chart itself. So the changes in the chart, it can be this side. This part right here is the end of diastolic volume. So if the end of diastolic volume period is extended, that happens in increase in preload and causes increase in stroke volume. Okay, that causes stroke volume increase, but this happens because of increased preload, or it causes, that's why you get that. Okay. The distance between the two lines right here is known as the stroke volume, right? And that's why the stroke volume also increases, because this distance increases from here to the green line over here. Okay? So you gotta remember that's preload. This right here, even though it's not written, This is the compliance, and that's how it is. So if it was like this, sorry, and it's between this and this one is increased, right? So this increase in compliance, and if it's down here, then it's decreased in compliance, right, from the original one. This happens in dilated cardiomyopathy. The compliance increases in that. Okay. Then we have, let's see, afterload. So the top part would be the afterload, right? So if you have extension of the top part, that's this part. That means the afterload is increased. Okay. So that's this part right here. That's the afterload. So if you see it go like the blue line, that means there is increase in afterload. So there will be increase in aortic pressure, right? Because that's basically the systemic pressure, and the systolic volume, stroke volume, sorry, is going to be decreased since there is total increase in total peripheral resistance. For example, your stroke volume decreases in that, and then you have increase in end systolic volume. At the end of systole, there will be fluid left, so there's increase in end systolic volume. When you have this increase, that's what that means. Decrease in stroke volume, increase in end systolic volume, and increase in aortic pressure. This line right here is known as the contractility, right? The brown thing right here. So the curvature is here instead of here, so that means the contractility has increased, similar to how compliance was from here to here kind of thing. Right, so the compliance increased here, so here the contractility increased. Okay. So when what this means is that there's also increase in stroke volume, this thing right here, right? Because the distance from this line to this line has increased, so stroke volume has increased, so you get increase in stroke volume. The ejection fraction is increased because again, stroke volume is increased, contractility increased, then you have increase in ejection fraction as well. And you won't have any fluid left after at the end of the systole, right? So there's decrease in end systolic volume as well. Okay, now that that's done, we can move on to the heart sounds. So you have ideally you have two heart sounds, right? In kids and athletes, you might have three. Okay, so the first heart sound is lub, and then comes the dub. So the lub is the closing of AV valves. So those are your tricuspid and mitral valves. So mitral valve, when it closes, here we can see that it's S1. After S1, you have aortic valve open. That doesn't have a sound. What does have a sound is when your semilunar valves close. So those are your pulmonary aortic. So here the closing of this will create S2, or also known as dub. So you get lub at S1, which is at the end of diastole, and then you have dub over here at the end of systole. Okay. Then you have two more sounds, S3 and S4. S3 is the one for high volume, and then S4 is for hypertrophic, right? So when you have a stiff wall and you splash water against it, it's gonna make sound compared to you splashing water against a bed of sheet that's hanging, right? So I think that's the best analogy I can come up with for that. And then S3 is just the the sound of high volume. So we'll learn about that over here. Okay, we're done with that. Heart sounds. S1 is mitral and tricuspid valve closure. Loudest at mitral area, because that's the closest, right, to the lateral wall. guess you should know this by now from your internship, at least, if not your clinical rotations. Um, I mean clinical theory stuff. So S1, mitral and tricuspid valve closure, loudest at mitral valve area. Sorry. S2 is aortic and pulmonary. It's important to know where this is because a shift in the area also represents what? Hypertrophy of left ventricle, and that way you can deduce what's happening. S2 aortic and pulmonary valve closure, loudest at left upper sternal border. Sorry. Okay. If you remember, if this is a person with the arms like that, and that's his torso, that's arm, and then this is the sternum, right? Then you do A, B, 2, and then you have men right here. So it's that's how I remember it. Ape to men. Right? So ape is aortic. Sorry. So aortic would be over here on the right side. That's what they're saying. And pulmonary is on the left side, and T is over here on the border of the sternum, and then you have mitral at like 6th intercostal space, or 5, between 5 and 6. Sorry, so 5th intercostal space. Okay. So aortic pulmonary valve closure, loudest at left upper sternal border. So it's loudest over here for dub, and for lub it's loudest over here. S3 in early diastole, during rapid ventricular filling, best heard at apex with person laying on his side, associated with increase in filling pressure. For example, mitral regurgitation, aortic regurgitation, heart failure, hydrotoxicosis, and more common in dilated ventricles, but can be normal in children, young adults, athletes, and pregnancy. Okay, so when I told you that you can hear 3 sounds in children and athletes, that's what I meant. It's normal in children, young adults, athletes, and pregnancy. So if they tell you that you hear a third heart sound in a pregnant woman, what does that mean? They'll give you all these disorders, and then last one will be like, it's a normal finding, right? And then you're gonna do your deduction for all the 3 or 4 of them, and you're gonna second guess yourself and pick a wrong one. Don't do that. It's normal in pregnancy, athletes, young adults, and children. Turbulence caused by blood from LE mixing with the end systolic volume. That's this thing right here. So that's how you get the S3. It's usually because of high volume and high resistance, right? Then you have S4 in late diastole, atrial kick, turbulence caused by blood entering stiffened left ventricle. Best heard at apex with patient in left lateral decubitus position, high atrial pressure associated with ventricular non-compliance, for example, hypertrophy. Right, so I already explained the S4 bit. Okay, can be normal in older adults, considered abnormal if palpable. Okay. Why? Because in older adults, you get increase in the left ventricular wall as well, and the interventricular septum as well. But the same finding can, if found in like a young person, it's hypertrophic cardiomyopathy, HOCM or something like that. Okay, so, and then you have this jugular venous pulse. So we'll do that after this diagram. So this diagram, know this diagram, at least this bit right here, that's what's going to be tested on. They will, so this thing is the most important thing, and it's what they ask. Okay. We'll do the ECG bit later. So it starts off with mitral valve closes. Okay, so that's your lug. So when the mitral valve closes, you have isovolumetric contraction, right? It contracts until so that's your isovolumetric contraction right here, uh, right? And then you have aortic valve open. When the aortic valve opens, you have rapid ejection, right? So the pressure increases during that time, uh, and then you have decrease in pressure after that. And then when there's not enough pressure, again, it took this much pressure to open it, but it's taking you gotta have at least a pressure higher than here to keep the valve open. Similarly here, uh, you need this much pressure to open it, which is a lower amount of pressure to open it, but you need at least this much pressure to keep it open. Anything lower than that will close the aortic valve. So uh, remember this difference of pressure here, and you're seeing it over here as well. Okay, because when we do it here, it might make more sense. Okay, so rapid ejection here. Okay, and then when the aortic valve closes, then what happens? There's relaxation of the ventricle, right? So that's called the isovolumetric relaxation, because the volume stays the same, it's just the pressure decreases. Okay, up to here, when the mitral valve opens. So when it opens, there is a little bit of fluid or blood coming in from the left atrium into the left ventricle. So when when it opens up, the pressure actually decreases, right? Because I guess the suction, you can think of, there was a suction mechanism going on with the isovolumetric relaxation. So when there's a hole that opens up, that means there's uh, basically the load of the pressure is being shared now with between two chambers. So that's why there's a decrease in this low pressure right here. So then after all of it is filled up, again, left atrium doesn't have that much pressure to begin with, and even when it contracts, it only goes up by up to like I think 12 maybe. That's it. So it's not too much pressure. So here after it fills up, it uses all of its 12 mmHg pressure and to get you up to here with the pressure, right? And yeah, so right before the mitral valve closes, the left atrium is like from this big thing, it's gonna be like this little thing right here now, right? So not too much pressure left. So that's the decrease right there before it closes. So when it closes, that's when the isovolumetric contraction begins again, and this whole cycle happens. Okay. So what happens to the aorta? Okay, so in the isovolumic contraction, it's closed, right? So it's closed, it stays the same volume right here, and the pressure is the same. When the aortic valve opens, then it it's basically about the same systolic pressure as the left ventricle, right? That's why it goes parallel to it up till this pressure, this amount of pressure. When this pressure it goes below this pressure, aortic valve closes. When it closes, there's a slight increase. It's known as the dicrotic notch. This increase is basically happening because of the way the valve closes, right? Because imagine the valve is like that, oh no, and like that, right? In the aorta. So this is your aorta, and then this is your left ventricle, right here, right? So it's going up into this. So when it's going like that, it's the same as this, but now what's gonna happen is when these valves close, they don't close like that. They close upwards, right? They're gonna go from here to here, like that, and this valve goes from here to here, like that. So when that happens, they're usually tricuspid, so it happens on like three different sides. Um, the last bit of pressure over here, when it closes, it pushes up. So this pressure is generated from this these valves rather than the muscles of left ventricle, right? That's what this pressure is made from. It's adding to whatever the pressure was from here to here, plus whatever this valve can create. So that's your aortic valve closing pressure. And this is also conveniently your S2, right? That's why you get that dub sound. That's what the S2 is. Okay. Okay. Yeah. Okay. So yeah. So we did the S1, the closure of mitral valve closes, and then S2 as well, right? S3, if there is you know and systolic volume, then you have S3 because of that. Over here in the rapid filling stage. Rapid filling, again, that's after the mitral valve opens, right? And mitral valve opens, the fluid comes in from left atrium into the left ventricle. And then you have S4 over here. S4 is at the end of systole, right? So atrial systole. So end of that right before the mitral valve closes. Okay, you need to know this as well because uh, they will give you a clip of audio sound of a murmur, and then the murmur will have like a S3 or S4, and so you'll make out what lub dub is, and then there will be a sound between dub and lub. So lub dub lub, right? So before that, so it would be lub dubs lub dubs lub dubs lub dubs, like that. So that so you have to focus on when you're hearing that sound. So if it's lubdubs, 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 that's S3. But if it's lubdubs, lubdubs, lubdub, that's S4. Okay. For this, just Google up the murmur clips and you'll find it on YouTube. There are enough of it, or you'll also hear it on UWorld. But learn to differentiate between them because they'll ask you something simple like that on step. They won't complicate it. Also on steps, they're gonna give you a body. Okay, so it's gonna be a guy laying like that. I don't know why the guy looks demented. Uh, but they'll give you a spot here on the A and the P and the T and the M side as well. So they'll give you four, or like they might give you one more over here for some reason to confuse you. So they'll give you these areas you can click on. So you can click on this, and then it'll play a sound over here, what you would hear on a stethoscope over here, or they'll give you a sound over here. So if you click it, you'll hear what you hear on a pulmonic side, or like the lateral side of the septum on the left side, or the mitral area, right? So then you'll hear at some places a murmur louder than say here, if the murmur is in mitral, right? But yeah, sometimes that's all they give you. They don't even give you the history if they're testing you on the sound itself. But they might just give you the history and the sound together. So if they tell you that the sound is radiating to axilla, it's probably going to be something to do with mitral valve, right? So that would help as well. Okay, so we did these. Now we gotta know what's happening to the left atrial pressure. Okay, so when the mitral valve closes, after it closes, it gets filled up from the pulmonary veins, right? The blood comes in during the isovolumetric contraction. That's for just 10 minutes left. Okay, so it's that comes in from there. It creates that left atrial pressure, and mitral valve opens, and then that's it. Yeah, so when it opens, obviously the pressure is going to decrease because all of its pressure comes from the fluid, and the fluid is getting leaked into the left ventricle. That's why it gets lowered after mitral valve opens. Okay, so know this, and then you gotta know why there are these waves. Okay, So the waves, we're gonna do that now. So the A wave comes from atrial contraction. Okay. So the atria contracts, uh, absent in atrial fibrillation. Okay. So when the atria contracts, mitral valve closes. Oh, right. Okay. So right before mitral valve closes, what's gonna happen to the right or left atrium, right? It's gonna push, so it's gonna create the pressure increase, and that pressure is this, and you'll see the pressure increase in left ventricle as well, right here before it closes, right? That's why it's only this much, right? Okay, got it. So then after it closes, it's fine. It does its own thing, left ventricle, and then the left atrium does what? Uh, it gets the blood coming in from the lungs, so it increases a little, but then that will stop as well, right? Why does it this decrease? Because in the heart, in the left atrium, that's the left atrium, and that's the left ventricle. When the fluid rushes out of the, when the aortic valve opens up, basically, right? Wait, no, I'm wrong. Okay, let's not confuse ourselves. We got it this far. That's good. Good enough. Okay, so C is right ventricular contraction, closed tricuspid valve bulges into the atrium. Okay, so yeah, so when this valve closes, and before this valve's opened up, the so just imagine this is right atrium now, and right ventricle, and this is the pulmonary valve right here. So before this opens and this close, after this closes, what's gonna happen? This thing is gonna press inwards, right? It's gonna contract inwards. So what happens to this is that it this pressure is gonna push onto this valve on the tricuspid, and that's gonna create your C wave. So that's the C wave. That's where it comes from for the left atrial pressure. Okay. You have X descent, that's atrial relaxation and downward displacement of closed tricuspid valve during rapid ventricular ejection phase. Okay, so atrial relaxation and downward displacement of closed tricuspid valve during rapid ventricular ejection phase, reduced or absent in tricuspid regurgitation and right heart failure because pressure gradients are reduced. They're not going to ask you about this. They might ask you about this or this, but not this. Then we have V wave, that's increase in right atrium pressure due to increase in volume against closed tricuspid valve. So that's V wave, that's over here after the mitral valve, right before it's closed. So right atrial pressure due to increase in volume against closed. Okay, so that is what it says it is anyways. Y descent is right over there. Right atrium emptying into the right ventricle, prominent into constrictive pericarditis, absent in cardiac tamponade. Okay. Why will you'll understand it when we do this, but right atrium. Oh, right. So what actually happens is, remember I told you, it's when the pericardial space is filled with fluid, so it's already creating pressure in the atrium, into the atrium, because atrium doesn't have that much pressure to start off with. So whatever pressure change was detected here is covered up by the pressure that's coming in from the outside due to the fluid in the pericardial space. Okay, so we're done with that. Now we're gonna do questions about these two in this page after the break. Percentage, they're always gonna tell you it's half. Okay, so a 49-year-old woman with coronary artery disease undergoes coronary arterography that shows a 50% decrease in the lumen of LAD, or left anterior descending. Hold on. left, no, LAD, it should be what was LAD again? What am I skipping on this? Left anterior descending artery. Okay, right. That messed me up. Okay, so for any AV pressure gradient, the flow through this artery compared with normal wall decreases by a factor of which of the following, right? So that's the question. Uh, so let's go through that question. Okay, so we know that whole formula, uh, the Postulate's law or whatever, right? So it was that thing. It's okay. What was the facility law? Let's see. I'm probably pronouncing his name wrong, obviously, because I butcher pronunciations. So it was resistance equals the 8n or viscosity times length divided by pi and r to the power of 4, right? So we are only concerned about the radius, and we don't have the other formulas, so it's r to the power of 4, right? Okay, and what do we put up here? What we know is that at the starting the artery was wide open, and that's the reference point, right? So we can just assume that the artery was at 100%. So one number, so we put that 1 over there, and 1 over 1 is 100%, right? And then they're telling you that it shows a 0.5, right? Or 50%, which is of half of 100%, or also known as 0.5, right? So you can put, instead of 1, you do 0.5, and that is your radius, right? So then all you do is 0.5 to the power of 4. Okay, so your calculator here, 0.5 times 0.5 times 0.5 times 0.5. So you get that, and then you do 1 divided by 0.625. And you get 16, right? And that would be the answer then. 16. Cool. Yeah. So that's how, very simple. Lumen is reduced by half's the size, therefore this and this. The flow through that is decreased by the factor of 16. That's the Poiseuille's law, is this. So the factor changes from that to that. Multiplication. And I showed you that in case you want to pause it and watch that later. Okay, continuing. Okay, so we did the left atrial pressure and the heart sounds. Ventricular volume, they won't test you on that, but it's basically up to the isovolumetric contraction. You have the volume over here, and then it decreases, right? And then you have mitral valve open, and then the volume comes in from the left atrium, and so it increases until again aortic valve opens. Okay. Then you have right atrial pressure curve. That's jugular venous pressure, right? Or JVP. So up till here it's the same, right? So atrial contraction happens, so this one goes up, right? And So just imagine the superior vena cava, if not the jugular venous, right? So you can just think of SVC. What's gonna happen to SVC when atrial contraction happens? So absent in atrial fibrillation, basically it's pushing against the tricuspid, right? So there's going to be rise in backflow of into the superior vena cava. So backflow of that will cause backflow of jugular venous pressure as well. So that's why there's an increase in jugular venous pulse as well, or RAP, sorry. Then it opens up, right? Mitral valve closes, it's up, and then the ventricle is gonna stop pushing into it, right? So right ventricle is gonna stop pushing into the atrium, and instead it's gonna go into the pulmonary artery. So the pressure decreases because of that. And the X is the descent, atrial relaxation, downward displacement of the closed tricuspid valve, right? So that's what causes that. And then you have the V, RA pressure, again, it's contracting, right? Isovolumetric relaxation of left ventricle causes isovolumetric contraction of the left atrium. So that's, you have that up there. And then Y is the descent again. That is right atrium into right ventricle empty. Okay. ECG, I'm sure it's given somewhere else, a better one, but it's P is the atrial depolarization. Okay. And then you have the ventricular depolarization over this bit, and then you have the repolarization over here. Okay. And then that's the T wave, that's just resetting of things. And then that. So again, atrial depolarization, right? So that's going to be your atrial systole. Okay, so that's what causes that. And then you get it goes to the AV node over here. So once it reaches the AV node, the isovolumetric contraction starts, because AV node sends in the electrical impulses throughout the whole ventricle, right? And then it starts contracting, and the contraction causes enough pressure to open up the atrial valve, aortic valve, sorry. And then contraction happens, and then it goes back, basically behind. I forget what T was. We'll come across that later. Okay. And that. So before we do anything, let's do this and fill it up black. Oops. And let's put that here so we can talk about this. So without looking at the sides, what do we know about the stroke volume to start off with? It's decreased here, right? This is, we are talking about aortic stenosis. Okay, that's when the aortic valve doesn't open. Okay, so what's going to happen when it doesn't open as fast as it needs to? Okay, so the stroke volume is going to decrease. Obviously, the cardiac output is decreased now, right? So stroke volume decreases. What's happening to this part right here? That was the afterload, right? If afterload is increased, what does that mean to the end systolic volume, basically, right? So end systolic volume was here, and now it's all the way here. So end systolic volume is decreased, right? No, increased, I guess. We'll make sure of that. The contraction is the same though, right? Because it's following the same curve like that. So the contraction, there's no difference in that. No difference in end diastolic volume either. So if diastolic volume comes from 100 to, I don't know what, I guess it's increased then, right? So it goes from 100 to 200. So if it's going from 100 to 150, it's increase in end systolic volume then. Okay, so that's increased, and that's all you can tell with this. But if you're given this chart, you should be able to recognize that this is a chart for aortic stenosis, right? Uh, so this is the pressure in aorta, the red line, right? Normally it follows up to here because as soon as the aortic valve opens, its systolic pressure of the left ventricle is similar to the systolic pressure of the aorta because this thing normally goes up here and then it makes the dichrotic notch, right? Like that. But this time it's all the way down here. So that means the pressure, the difference between the pressure, right? That's because of aortic stenosis. Even though after it opens, it doesn't open fully, so not all the pressure is transferred completely. So some of the pressure, the valves are gonna take a hit for that when it's going. So only a little amount, like a lesser amount of pressure is transferred to the aorta. Okay, and that's why you have this left ventricle pressure more than the aortic pressure. So there will be dichrotic notch when it closes, but uh, the pressure is less. So if they just gave you a chart like this and they give you a aortic line like this, you should know that's because of aortic stenosis. That's like a giveaway. Okay, so let's see if we got that. So there is increase in left ventricular pressure, right? So that's left ventricular pressure. That's up here instead of here. There's increase in systolic volume. We already did that. Systolic volume is over here. Diastolic volume is on this side. So it went from here to here. So increase in systolic volume. No change in diastolic volume. That's over there. F mile. And there's decrease in stroke volume. We did that as well. Right? Ventricular hypertrophy will cause decrease in ventricular compliance and increase in end diastolic pressure for given end diastolic volume. Oops. Okay, so ventricular hypertrophy will do what? It decreases the ventricular compliance, obviously, and there will be increase in end diastolic pressure. Okay, for given end diastolic volume. We have aortic regurgitation. Now there's a backflow of fluid from the aorta into the left ventricle. So that will give you more volume in the ventricle during diastole than normally available there, right? So that backflow is going to cause increase in end diastolic volume. So it's over here now instead of here. So that's an increase in preload or end diastolic volume. There's also an increase in stroke volume, right? The contraction is the same. The pressure on top is like almost similar. So there's no, maybe a slight increase in the afterload if they want to mention it. Okay. The compliance is also the same like that, right? It always goes like that. So compliance contractility is the same. Over here we see that since it's regurgitation, there is a decrease in the volume, right? Normally it starts up over here and then that's where it comes in from, but there's a decrease in volume even before the aortic valve opens, right? Because there's regurgitation happening. So it's going back into the left ventricle until it opens up. Then the left ventricle pushes itself up again, right? And even this is skewed, right, for the left ventricle because it already has a little more volume than here. So normally the volume starts over here, but now it's starting all the way here. Right? There's a pressure volume curve, right? Pressure volume loop. So you need to know what the line is. They don't tell you that. Okay, so the volume was increased even before it started, and then there's a decrease because of that. But then the left ventricle is working properly, so its systolic pressure is going to be the systolic for aorta as well, so it goes all the way up here. Then the aortic valve closes here. The closure will cause this little bump, but after the closure, because there's regurgitation, the pressure is not gonna keep sustained, right, as it is sustaining up here, because there's gonna be a drop in pressure volume, so that will lead to a drop in pressure as well. So large pulse pressure in here. So large pulse pressure is known for aortic regurgitation. Let's see if you got that right. No true isovolumetric phase, right? The volume keeps on, even during the relaxation, it keeps on adding to it. There's increase in end diastolic volume, we got that. Increase in stroke volume, we did that. And loss of dichrotic notch. So that little sustaining it doesn't do is loss of dichrotic notch. Okay. We have mitral stenosis. So here there's going to be a problem with the preload, right? So right off the bat, the preload is decreased. Preload was at 150. Now it's at like not 150, like 185 or 180, and now it's at like 150. So that's a decrease in diastole. There's no afterload increase. LV pressure is a little less. The contract compliance is similar, but what has decreased is the stroke volume. Right. That's this to this. So stroke volume decreased, and diastolic volume has decreased. Okay. And here, blood pressure. The left atrium more than the left ventricle pressure, because that is the left atrium line, right? So the pressure in left atrium is going to be more because, again, left atrium doesn't have that much power to push. So it's going to use up all its energy to open up the mitral valve. Okay, so it's constantly under a lot of pressure, because even after it opens up, it doesn't leak out all the blood. Some blood will still stay in mitral valve, and that's the reason you get thrombus formation in the left atrium in mitral stenosis, which can cause heart blockage or heart failure kind of thing situation for you. Okay, so nothing's wrong with the aorta, so it's just gonna follow the pressure gradient of the left ventricle. It's just a little smaller. Okay, so left atrium pressure increases in mitral stenosis. That's over here. Decrease in end-diastolic volume because of impaired ventricular filling, we did that. Decrease in stroke volume, we did that. There's a slight decrease in this little thing right here, so, and systolic volume as well. Okay, I don't know where this thing comes from. Like, I can explain it in words, but from the chart you just look at that and that. It's again after lunch, so I'm feeling sleepy now. Mitral regurgitation. Okay, so in mitral regurgitation you have increase in preload, so your diastolic volume increased. Decrease in afterload, so this decrease and systolic volume decreased. And decrease in afterload as well. Okay. You have increase in stroke volume. The compliance is the same, so it's following the same curve like that. The contractility is decreased, I guess. It was up here, and now it's up here. So contractility decreased. Okay. Over here we see that after the mitral valve closes, the mitral valve is leaking through. So blood from left ventricle is going back into the right atrium. Left atrium, right? So that's why you get the leakage back into the thing. So that's why this tall V wave you have over here. Because normally it's down after mitral valve closes, right? But now you have blood coming in as this is happening, isovolumetric contraction is happening. Since it can't go through aortic valve, it's going to go through the mitral valve into the left atrium. So that's why you have this pressure gradient going up for that. Everything's same for this. Upper part, left ventricle, aorta, both function normally. Right, so let's see if that makes sense. There is no true isovolumetric phase because it can't go through aorta, but it can go through the mitral regurgitation. So that there's decrease in end systolic volume due to the decreased resistance and regurgitation. So when it does manage to push through aorta, it doesn't mean it's going to push everything through the aorta, right? Now it also has the mitral valve that's regurgitating. So when the left ventricle pushes into the aorta, it also ends up pushing a little bit through this thing. So that's why you have decrease in end systolic volume due to the decreased resistance and increase in regurgitation in the left atrium during systole. So this thing is going to push it in. Okay. Then you have increase in diastolic volume. We did that over here, right? Due to the increase in left atrium volume pressure from regurgitation. So now that the volume is this much plus the volume that normally it carries, there's increased amount of volume altogether, right? So all of that is going to come back into the left atrium. So the end diastolic volume is going to be increased because of that. And then there's increase in stroke volume. We did that. Forward flow into the systemic circulation plus backflow into the left atrium. Know these curves, know the defining features and the distinctions. If the pressure is low in aorta, it's always going to be aortic stenosis. If there's a loss in aortic dicrotic notch, it's always going to be because of this. And also make sure you look at this bit right here, because if that tells you that there's no isovolumetric phase, contraction phase, and that only happens when there is a regurgitation of some kind, right? So it could be aortic regurgitation, or it could be mitral regurgitation. Well, not mitral. Okay, so it can only be that. Okay. Mitral won't have proper contraction. That's what it won't have, because it's going back into the left atrium, not the okay. For mitral stenosis, defining feature was this right here, the left atrium curve. So it starts all the way up here instead of down here. Okay, so mitral stenosis increases the pressure in left atrium. And mitral regurgitation at the end, you need to know this thing. If it's like that, it means that there's mitral regurgitation. You can figure this out on the spot if you know what the graph means and everything. So, but it's faster to just memorize it and then you can just go with that. Okay. They didn't talk about contraction here, so I don't know why, because there's a difference in contraction as well. And it would make sense because mitral regurgitation makes some kind of remodeling of the heart. Okay, so now we're doing splitting of S2. Physiologic splitting. That's just normal. So inspiration leads to drop in intrathoracic pressure, which causes increase in venous return, which leads to increase in right ventricular filling, which causes increase in right ventricular stroke volume, which causes increase in right ventricular ejection time, and this causes delayed closure of pulmonic valve. So what does that mean? Just okay. I'm not sure. So what does that mean? So basically, it's saying try breathing right now. So what's gonna happen when you're breathing? There's a negative pressure in the thorax, right? So a drop in intrathoracic pressure, because your outer chest wall is pulling outwards, and it's creating negative pressure in the lungs, right? So negative pressure in the lungs will cause intrathoracic pressure. Sorry, it's gonna cause decrease in venous return, like that. Okay, and then you have, I don't know why I'm redacting this information. Okay, so drop in intrathoracic pressure when you're breathing, right? This happens. So intrathoracic pressure decreases by diaphragm, right? So your diaphragm pushes upward, and then like you can just think of like abdomen is pulling in the blood basically. So that's why you have decrease in venous return. So when you have decreased venous return, you'll have decrease in right atrium filling, and then that will cause. Sorry, wait. No. I was right initially. Okay, so negative pressure in the lung will pull in more blood. So when you pull in more blood, you have decrease in increase. Sorry, I keep saying decrease for some reason. Increase in venous return. So increase venous return in right atrium to right ventricle filling, and then right ventricle will put out more pulmonary output, right? So that's your stroke volume, and then this will increase the RV ejection time, because it has now more volume to push instead of the normal one that it was pushing, because now there's increase in venous return, right? So this low amount of time is why there's a delayed closure of pulmonic valve. On the other side, the aortic valve has already closed, right? So that's the difference. The sound of closing of aortic valve and the pulmonary valve, there's a difference between like a low amount of time between the two. So that's the sound that they're talking about. That's called splitting, physiological splitting. So decrease in pulmonary impedance, increase in capacity of the pulmonary circulation also occurs during inspiration, which contributes to delayed closure of pulmonic valve. Okay. Then you have wide splitting. So that's S1 and that's the S2. And during expiration, it's the same, but during inspiration, pulmonary valve closes a little later. Okay, you have wide splitting seen in conditions that delay RV emptying. Okay, so that's your pulmonary stenosis or right bundle branch block. If you don't know what bundle branch is, it's these things right here would be your right bundle branch. Okay, right there. So right bundle branch is pointing towards it. So from here, the electrical impulses come from here, right? But say there's a block, some kind of block over here, and it's not able to do that, then you're gonna have a delay in that too. Oh, don't want that. Okay. Alright, so it's seen in that right bundle branch block, and pulmonary stenosis causes delayed pulmonary causes delayed pulmonic sound, especially on inspiration, and exaggeration of normal splitting. Okay, so normally it's going to be a little wider apart, but even with inspiration it's going to be even wider than that. So in a question stem they'll just tell you that a wide splitting is heard of S2, and that should just give you a hint to what the answer is going to be. It's going to be one of these two. Okay. So for this, the mnemonic is a wiper. Wiper. Wide and then PR for pulmonary stenosis or right bundle branch block. Then you have fixed splitting, that's heard in ASD, right, atrial septal defect. Mnemonic for this is first aid or FA. Okay, so in fixed splitting is FA for ASD, atrial septal defect. Alright, so atrial septal defect will lead to left to right shunt. Right, because left side is stronger than the right side, so it's gonna push the blood through the septal defect, and then you have increase in right atrium and right ventricle volumes. So this volume then it increases flow through the pulmonic valve, and which causes the delayed pulmonic valve closure independent of respiration. So respiration doesn't have an effect of this on this, and that's why it's going to be fixed. Okay, so fixed is for FA, which is ASD. Then you have paradoxal splitting, and this is your PAL. Okay. So paradoxical splitting, if they give you that, it's heard in conditions that delay aortic valve closure. So you have aortic stenosis for that and left bundle branch block. Okay, and this is on the left side now instead of the right side. So wiper, FA, PAL. Okay. Normal order of semilunar valve closure is reversed. In paradoxal splitting, P2 occurs before A2. On inspiration, P2 closes later and moves closer to A2, paradoxically eliminating the split. Okay. And on expiration, the split can be heard opposite to the physiological splitting. Okay, so this is a normal one, and then this is the other one. So normal order of semilunar valve closure is reversed. So in paradoxical splitting, P2, so pulmonary closes before the aortic. On inspiration, the pulmonary closes later, right? And that's why it sounds closer to the delayed aortic closing. On inspiration, P2 closes later, moves to the aortic. So paradoxical, eliminating the split. Okay. Normally the split is not heard during expiration, and then it's heard during inspiration, but here during inspiration it's not heard, but it's heard during expiration. So that's why it's called paradoxical. So remember, PAL for paradoxical aortic stenosis and lateral branch block. FA is for fixed splitting that happens in ESD, and wide splitting happens in wiper. So P for pulmonary stenosis and right bundle branch block. Okay. This is again evolution goes from ape to man. So, A on the right side, and then you have P on the left side, T on the left side, and M on the over here. For the aortic area, it's only going to be stenosis. Same thing with pulmonary, it's only going to be stenosis. And then you have the tricuspid area with the regurgitations, and then this middle area where left sternal border, where you're going to have the aortic and pulmonary regurgitations, and the mitral valve is going to have both of it. Okay, so now aortic area, systolic murmur, aortic stenosis, right? So aortic stenosis there. You can have the flow murmur. This is physiological murmur, and then you can have aortic valve sclerosis. Okay, and then pulmonary area, systolic ejection murmur. That's this area, pulmonary stenosis, atrial septal defect, and flow murmur. Right. So again, these two are the stenosis ones. Okay, and then you also have atrial septal defect can be heard over here. Okay, because you won't hear it coming from the right to left. You're gonna hear it from going from left to right. That's why it's on this side. And then you can have the flow murmur there. Then you have this left sternal border. So that's this part. This is the sternum right here. Right, and then the Ziphy process or whatever. And then on right over there you have systolic murmurs. So all of these were systolics, okay? So systolic murmurs in these areas, you hear stenosis, S for S. S for S. And here, left sternal border. So you won't hear any diastolic murmurs over these two areas. You'll hear it at the left sternal border though. And the first two diastolic murmurs you hear are aortic regurgitation and pulmonary regurgitation. So we are done with aortics and pulmonaries, right? So aortic stenosis in the aortic area, systolic murmur. In pulmonary area, systolic murmur is going to be pulmonary stenosis. In left sternal area, diastolic murmur is going to be aortic regurgitation and pulmonic regurgitation. For systolic murmur, it's going to be hypertrophic cardiomyopathy. That's because there's increase in interventricular septum, and then so what happens is, imagine this is the aorta, okay, and normally this is your interventricular septum, right? But what happens is during hypertrophy this becomes bigger and it starts occluding this thing, the opening of the aorta. So before, when the thing was able to go through easily, now it's getting squished in by this. So now it's got the pressure is created here, and that's the murmur you hear during systolic when the LV is pushing in. Right? So that's what the hypertrophic cardiomyopathy, how that creates systolic murmur. Okay. Then tricuspid area. Now you have hollow systolic murmur here. That's it could be tricuspid regurgitation or ventricular septal defect. So ventricular septal defect, you'll only hear it on tricuspid side, not this side. Okay. Then you have diastolic murmur there as well. So you have tricuspid stenosis for the murmur in diastole. So you gotta remember here the systolic murmurs were stenoses, and when you go down it flips around. Hey, that rhymes. And when you go down it flips around. So in tricuspid diastolic murmur is going to be tricuspid stenosis, and the systolic is going to be the regurgitation, and you'll have VSD there as well. For the mitral, it's similar. The systolic is going to be the regurgitation, but here instead of the VSD you have MVP. Okay, and the diastolic murmur is going to be mitral stenosis. So memorize those because these are like the giveaways if you remember this stuff. Which ones are diastolic? Which ones are systolic? Systolic is the one where uh, it's emptying into the aorta, and diastolic is the one where it's filling up in the left ventricle. Just so you remember, and second intercostal spaces for aortic and pulmonary. Left sternal border at 2 would be this part right here, and at 4 intercostal space would be this part right here. And then this would be your 5th intercostal space for the mitral valve. Okay, now the maneuvers. These are important to know as well, and I'll try to clear up the image for this. How much time do we have? Time. Okay, so maneuver, cardiovascular changes, murmurs that increase with maneuvers, and murmurs that decrease with the maneuver. Okay, so when you're standing, what's gonna happen? If you stand right away, it's gonna create a negative pressure in your vein and vessels, right? So that will decrease the venous return. If there's a decrease in venous return, what does that do to the what does that do to the volume in right atrium? It decreases it. So if there's a decreased amount of volume coming in, that also means there's going to be decreased amount of volume in left ventricle. So that's why you have decrease in preload. Okay. For the Valsalva maneuver, the strain phase, that's when you're, Valsalva maneuver. Okay. So it's like this guy, right? You're pushing in like that, and that's a horrible picture. Thing. Okay, that's for the vessel maneuver for the ears. We'll just try to figure it out like that. So when you're doing that, what's happening here is it's creating more resistance, right? It creates more resistance when you're doing the straining phase. Okay, so when you're creating resistance, that means what? You're gonna have decrease in preload as well, right? Because venous return is gonna be decreased because it's low. Right. So that's why you get decrease in preload when you can just try doing that, and you'll see. So when you have decrease in preload, what happens to the thing? Maneuvers. Okay, so what happens to the mitral valve? If it's prolapsed. You'll have MVP, decrease in left ventricle volume with earlier mid-diastolic clip. Okay. Yeah, for this I'm just going to remember it. At this point I just remember these. So I think I'll just confuse myself if I try explaining it. So just remember it the way it is. Okay, so we have MVP and hypertrophic cardiomyopathy that decreases the murmur. Sorry, that increases the murmur with this maneuver. Okay. Okay, increases. Decrease in preload. Okay, whatever. And then you have most murmurs, which is decrease in flow through stenotic or regurgitant valve. Okay, so these ones decrease. So know this whole chart basically. That's important. Then you have passive leg really raise, so that's gonna increase the venous return rate. So that's gonna increase preload. Then you have squatting. Here you're creating more resistance on the peripheral side, but you're also increasing the preload because now you're closer to your legs, so the blood can travel into your heart faster, right? So that will increase the preload, but since you're also creating resistance, uh, the blood going through the aorta is going to be backed up now because of the resistance. So that resistance is going to cause increase in afterload. Okay. Most of the murmurs are going to increase because of this. So increase in flow through stenotic or regurgitative valve. MVP, increase in left ventricular volume with later diastolic flick, and HCV. So the ones that were increasing here are now getting decreased over here. Okay. For the hand grip, so when you're doing hand grip, what are you doing? So when they say hand grip, nope, that's not what they mean. That's not what they mean. I guess we gotta go back to Google for that. Basically, it's just two hands, pulling each other kind of thing. That's the way I imagine it. I don't actually know what type that is. I forgot. But whatever you do, it's gonna increase the resistance, right? The peripheral resistance. So when that is increased, you're increasing afterload. Okay. And increase in reverse flow across aortic valve. So increase in left ventricular volume. Okay. Okay, that's what that means everywhere else. The left ventricular volume decreases, so when it decreases, you'll hear it a lot more because now there's more area in the chamber to make the sound in. Okay, that's why. But that could be true for these two, so I don't know how that would help you remember that. But yeah, okay. So most other left-sided murmurs, why left-sided? Because those are the ones getting affected due to the resistance. Right. So aortic regurgitation, mitral valve regurgitation, and ventricular septal defect. Even though remember, they said that this is on the left-sided murmurs, but it's actually on the right side you hear it, under tricuspid, ventricular septal defect murmur, holosystolic. Okay. Then you have atrial septal defect, aortic stenosis. That decreases because of this hand grip, so you won't hear it because again, there won't be enough pressure to even, make the sound or whatever. And then you have hypertrophic cardiomyopathy for both of these things on this side. Then you have inspiration. Inspiration will cause increase in venous return to the right heart and decrease venous return to the left heart. So most right-sided murmurs, because that's where the blood is mostly, and decrease for most left-sided murmurs. Okay, let's wrap that up. Standing Vasova increases MVP and HCM murmurs and decreases most of the other murmurs. Why? Because it decreases preload, which decreases left ventricular volume. The passive leg raise will cause increase in preload, so increase in LV volume. And then you have squatting, increase in preload and increase in afterload, because you're increasing venous return but also increasing the peripheral resistance for the aorta. And then most of them you'll hear it, and then the ones you won't hear is MVP and hypertrophic cardiomyopathy. Hand grip increases resistance, increases afterload. Right. So most of the left-sided ones are the hurt ones, and you don't hear aortic stenosis and ACM for that. And then for inspiration, most right-sided ones, and you don't hear the left-sided ones. Okay. Heart murmurs, aortic stenosis. Hold on. There's also one for nitroglycerin. So nitroglycerin would go here. Glycerin. It decreases preload because vasodilation, right? So that decreases venous return. Preload. Okay. It increases the murmur intensity for these, and it decreases left ventricular blood volume. Okay. Increase in S3 at end of expiration. I don't think that's for this. Maybe for something else. Okay. But remember, for NTG, it decreases preload, so when it decreases preload, you're gonna get something similar to this stuff. This one. Sorry. Okay, heart murmur, systolic and diastolic. Okay, and then you have a continuous one. I like doing these backwards because it's once you get these, and then you just don't have to memorize the systolic ones as much. So let's go backwards. Continuous. So pain ductus arteriosus. You have S1, lub, and dub. Okay. Again, go to YouTube and listen to all of these because you need to know what they sound like. So lub dub there. This is closure of mitral valve. This is closure of aortic valves, or pulmonary, mitral and tricuspid over here. So this is the buzzword that they will use: continuous machine-like murmur. If you hear continuous machine-like murmur, it's gonna be about PDA. The question's about PDA. You might just have to, figure out that it's this, and then you're done. So it's best heard at left infraclavicular area, and loudest at S2. Or they might say that they heard this. What's the best way to manage this, or something like that? Again, to close this, we get what? Indomethacin, right? So, like murmur, best heard at left infraclavicular area, and it's loudest at S2. Okay. Often due to congenital rubella or prematurity. Right. Remember these causes. So congenital rubella is important because of PDA, and then you have prematurity that can cause this. So you need a patient for that machine. You need a patent for that machine. That's how you remember that one. For this one, it's just the operating system is Microsoft. Right, so OS in MS. So if you hear opening snap, that's the one closest to S2. So it follows, and remember, all of these murmurs are going to be heard after the aortic and pulmonary valve closes, because it's diastolic, right? So follows opening, snap, delayed rumbling, mid to late murmur, decrease in interval between S1 and OS correlates with increase in severity. So the closer this one gets to S1, because S1 is on this side, so this would be S1 again. So the closer this distance gets to this, the higher the intensity or severity, sorry. You need to know that. There are questions about that. they ask you how would you know how severe this is. Well, the distance decreases in severity. Okay, so this is clinical association and notes. Okay, so late and highly specific sequelae or rheumatic fever. Chronic MS can result in LA dilation and pulmonary congestion. Atrial fibrillation, Ortner syndrome, and hemoptysis, right heart failure. Okay. Mostly it's going to be about the rheumatic one, but the chronic one can result in left atrial dilation because, again, we did that, right? So it was something there, this was something here, and then you had the aorta on this side. So this was your left atrium and this was the esophagus. So esophagus there, left atrium there. So if this gets bigger, what's it going to do? It's going to push into this, right? So you're going to get the Ortner syndrome over there. And the left atrium is dilated because of the pressure, pulmonary congestion. So if pressure is built up here, the blood coming from the lungs are going to be backed up. So that's where you get the pulmonary congestion. Then you have Ortner syndrome, hemoptysis. You bleed through there as well in your mouth. Right heart failure, right? Because you get that Eisenmenger syndrome happening. We'll learn about that too. Not operating system, but opening snap due to abrupt halt in leaflet motion in diastole after rapid opening due to fusion at the leaflet tips. So left atrium pressure is way higher than left ventricle pressure during diastole. AR, aortic regurgitation. This is the one with the head bobbing and water hammer pulse. So only two diastolic murmurs. If they tell you that there's a diastolic murmur heard at the apex, it's going to be mitral stenosis. If they tell you that diastolic murmur is heard on the left side of the sternum in the second interventricular space, then it's going to be aortic regurgitation. And that's a dead giveaway because it can't be anything else, right? Just a sec. You probably heard all of that. Sorry. Okay. Early diastolic decrescendo. So this is crescendo. This is decrescendo. And then this is crescendo decrescendo. Okay. That's just the wave names for the waves from music. Okay, so early diastolic decrescendo, high pitched blowing murmur sound, best heard at base. Okay, so aortic root dilation or left sternal border, valvular disease. So I already told you those. This one we don't have a location for it unless they tell you it's over here, but we have a location for this thing, so they'll give you that. And they might even use the word blowing, which would be a buzzword for this. Okay, so continuous machine like what's this, blowing is this, and then you have operating snap over here. Okay, so mnemonic for this can be something like assault rifle, so AR, assault rifle. I'm gonna blow people up with assault rifle or something. Hopefully I don't get FBI at my door now. Let me just not bother writing that, just remember it. Okay. So that could be a mnemonic for that. because it's the blowing one, and AR is assault rifle if you are into guns or know anything about it. Okay. Cause includes BARE, so bicuspid aortic valve, endocarditis, aortic root dilation, or rheumatic fever. So rheumatic fever causes this and this. Right? It can cause both. Aortic root dilation happens, which causes this obviously, and endocarditis or bicuspid aortic valve can also cause this. These ones are a little tricky to remember, but these ones should be, you should know these for sure. These two. Okay, so pulse pressure, also known as water hammer pulse. You have the pistol shot femoral pulse. Oh, see, all these gun references. Then you have pulsing nail bed or quink pulse. I guess they added this new thing. Okay, so pulsing nail bed, you get. But if you know water hammer pulse, then that's probably the one they're gonna ask you about. Because what does that do? It makes your head bob, right? So hyperdynamic pulse and head bobbing when severe and chronic can progress to left heart failure. Okay, that's it. And now we're going to do the systolic ones, the ones that cause murmurs due to ventricular contraction in the left ventricle. Okay, so you have aortic, left or right ventricle, but aortic is going to be your crescendo decrescendo, right? So crescendo decrescendo right here. Ejection murmur, then you have loudest at heart base and radiates to the carotids. So if they tell you that it's carrying murmur into the carotids, it's going to be aortic stenosis. Soft S2 pulse, they give you this, that a soft S2 is heard. So that could also hint you that it's this. With or without the ejection click. So that's easy. Right, so you have pulses parvus et tardis, weak pulses with delayed peak. Okay, so they're weak and they're late pulses, weak and late. Okay. In older, more than 60 years old patients, most commonly due to age-related calcification. In younger patients, most commonly due to early onset calcification of bicuspid aortic valves. So remember this because it's important. They might say that there's calcification of nodes in a 70, 80-year-old patient. What could be the cause of this? And you probably pick like rheumatic fever or something, I don't know. But pick the one that says it's normal in aging, it's due to age or something like that. So that would be the answer for that. It can lead to syncope, angina, and dyspnea on exertion. Sorry. Why? Because it requires more blood, and then this one's hampering that supply. So a hampering supply to the brain will cause syncope, to the heart will cause angina, and to the lungs will cause dyspnea. Because it has to come back as well. So left ventricle pressure is more than aortic pressure during systole. Then you have mitral and tricuspid regurgitation. These are your hollow systolic ones, so that's easier to remember. This and this is your hollow systolic. Mitral is going to be at the mitral area, tricuspid and ventricle are going to be at the tricuspid area, and they are going to be hollow systolic, right? So hollow systolic, high pitched blowing murmur again. So this blowing and this blowing. So if it's diastolic blowing murmur, it's going to be AR. But if it's systolic, then it's going to be this regurgitation and not the aortic regurgitation. But blowing only happens in regurgitation. Okay. So how's this like high pitched blowing murmur? MR, loudest at apex, radiates towards axilla. Right? That's a buzzword for axillary mitral regurgitation.